You tell me. You tell me. Good morning, good afternoon, and good evening, ladies and gentlemen, and my dear colleagues. Today, it is the fourth day in the series of webinar, Kerala Health, Making the SDG a Reality. Department of Health and Family Welfare, Government of Kerala, indeed honored and privileged to have experts from all parts of the world for this seminar. We were all eagerly waiting for this fourth session, which is on non-communicable diseases. Meet the SDG, beat the NCDs. We are having galaxy of eminent speakers today lined up. So I heartily welcome all our distinguished guests who have very generously agreed to join this webinar. I heartily welcome all my colleagues who will be today telling in Kerala what all things we do. I also heartily welcome our Honorable Minister for Health and Family Welfare, Social Justice and Women and Child Development, Madam K.K. Shailaja Teacher, who will be joining us shortly. Without much ado, I will now request my colleague, Dr. Satishan, to come forward and introduce our first guest speaker of today's session. Over to you, Dr. Satishan.
Thank you, sir. Greetings to all the participants from God's own country. Dr. Cherian Verghese, he is a coordinator of management of communicable diseases and WHO Geneva, and he has been a radiation oncologist by profession, and he is involved in the cervical cancer elimination strategy, working in WHO. Now, I request Dr. Cherian Verghese to deliver his keynote address. Thank you.
Good morning, good afternoon, and good evening, Kerala. First of all, let me thank the Honorable Minister of Health, Kerala, and the Principal Secretary, Kerala, Sri Dr. Rajan Kobragade, and the Kerala team for giving me this opportunity. As a Malayali and as somebody who has worked in Kerala for about 10-15 years in the field of NCDs and cancer, I'm very pleased to sort of give these opening remarks on Meet the SDGs and Beat NCDs. I'm adding a subtitle called Towards a Healthier Kerala 2030. I hope you're seeing my slides. Let me start with the good news. I don't know how many of you know that Kerala has won the UN Award for Outstanding Contribution towards Prevention and Control of NCDs in 2020. This is one of the UN Interagency Task Force Awards, which shows that Kerala is already on the right path towards the prevention and control of non-communicable diseases. Now, today's theme is towards SDGs, and all of you know better than me the context in Kerala. I just want to give a few highlights. First of all, when we say premature mortality reduction, that is the target 30% reduction in premature mortality from NCDs by 2030 is the SDG target. That is mortality between 30 and 70 years of age. Kerala has got a very high life expectancy in male and female. The top 4 risk factors, this is from the India GBD study, shows high blood pressure, unhealthy diet, high plasma glucose, and obesity as the major risk factors. The top 4 causes of years of life lost are ischemic heart disease, stroke, suicide, and COPD. So we are in a separate conundrum compared to rest of India and in many other countries of the same situation. Even if you look into COVID in a very different lens, you will see CVD coming, which is cardiovascular disease coming out of COVID, as most of the COVID deaths were in people with cardiovascular diseases. So with that context, let me get into solutions very fast. First of all, we have to look at making healthier choices as the easier choices. Because you see this picture of Kerala with the obesity manifested, and I have this picture of bottles, which is lightly putting the lifestyle changes in Kerala. In the first 2 years, instead of breast milk, children are on bottle feeds, then on sugary drinks, and then they get into alcohol, and finally in an IV bottle, which all cost a lot of money for the individual and for the state. So in addition to health literacy, we need to use 3 major government policy instruments. One is regulation, one is legislation, one is taxation. Regulation is to make trans fat free foods available, foods low in salt, sugar, and saturated fat. There should be spaces for physical activity, healthier transport options, reduce air pollution, and work on urban planning. Legislation use every option possible to reduce tobacco and alcohol availability and not to increase the availability, as in some places that we see. Differential taxation is needed. It is easy to tell people to eat healthy, but then healthier products cannot be expensive. We have to make healthier products easier and cheaper, and unhealthy products more expensive. And this has to be supported by health literacy. NFHS 5, fifth round of 2019 and 2020 has given us little more perspective into the morbidity of Kerala. Half of the people are obese or overweight. 1/4 of the people have diabetes. 1/3 have hypertension, and 1/5 have tobacco or alcohol use. That is not the right mix of things that we want. And what I wanted to highlight here is that this is going to make people with multimorbidity as the norm. There is very unlikely that a person comes into a primary health center with just one condition. And one approach that WHO is taking on this is called the total cardiovascular risk, which can be easily assessed with total cholesterol, diabetes status, systolic blood pressure, age and gender, and smoking status. And then we get the overall status of the person. Then, of course, we can have targeted approaches for hypertension, diabetes, and statins and all that within that. So I think the PHC approach to NCDs have to go into a multimorbidity management approach. I was just part of this Lancet paper, which just came out this Tuesday on improving lung health. I know that Kerala has started this excellent program called SWAS, which is to look at primary healthcare management of chronic respiratory diseases. But the increasing air pollution, tobacco, and other factors are adding to the lung health problems. And again, for improving lung health, Kerala has to take a health in all policies approach, which should cover health, transport, housing, work, nutrition, etc. Kerala is quite capable of doing this, but I think in all these areas, what I'm just suggesting is scale up and more coordinated action so that we have impacts. When it comes to primary health care, the Madam Shailaji teacher and Dr. Rajan Kobragade came to Geneva actually, and then all the people in Geneva were asking, oh, we will come and learn PHC from Kerala. So Kerala is known for the PHC approach, and the FHCs have really made a big impact. So in my view, NCD, mental health and aging related services will define the family health centers of Kerala. There are a lot of staff members, I agree, but my plea to the government will be to consider a public health officer in each FHC, a person trained in public health who knows disease surveillance, who knows public health, who knows community engagement. In addition to the good trained clinicians in the FHC will make a difference. The FHCs should look at hypertension control. I know that Dr. Tom Frieden will speak later. He will expand on such things. We should also be looking at cardiovascular risk reduction and reduction in amputation, because the PHC should be the sort of gatekeepers so that conditions are not advanced to end organ damage. Another thing I wanted to bring out is that people are not going to be in the traditional settings. Even in rural parts, the address of people in Kerala is going to be 24th floor and 17th floor. And people who are living in such crowded urban environment, what is the new primary healthcare model that we have to look at? Maybe a digitally enabled self-care has to be looked at. The COVID kiosks were beautiful. Why don't we convert them to Beat NCD kiosk and make it available so that people will know what is their NCD status? There is no way but to manage the end organ damage. We can prevent heart attack, stroke, and kidney and liver disease, but there will be a large number of these conditions. This again has to be organized in a way like a hub and spoke model. I'm aware of the STEMI India models which are happening in Goa and in Tamil Nadu. Kerala also has such programs, but that has to be scaled up so that in each geographic area, you know exactly what is the system that needs to take care of these conditions. Of course, supported by financial protection, which is happening with the convergence of insurance, and rehabilitation without delay, and palliative care, which again has got a good Kerala model. I know there's a galaxy of speakers on cancer control, but again, somebody who started the career in cancer control in Kerala, let me start by acknowledging Dr. M. Krishnan Nair, who put the vision for Kerala's cancer, which even is taken up in many parts of the world. For Kerala, in addition to everything that everybody is going to say, I would think HPV vaccination and targeted screening can actually eliminate cervical cancer to a rate of 4 per 100,000, which is feasible because we have around 10 per 100,000 in the PBCRs that we have. We need to ensure seamless care. I still think that people are still going here and there. So a seamless care for every cancer patient is important. We should look at survival rates, not just the number of cancers seen. The number of cancers seen in a cancer hospital is not the full story. Each cancer hospital should come out and say, this is my survival rate by stage. And we need a state cancer registry, and mandatory reporting is the way to go, as we have seen from Tamil Nadu, which has just published the first state cancer registry report. Now, this is all fine. How do we do this? So these are my last 2-3 slides. One is we have to build public health capacity in Kerala. We have medical schools, more than 100 nursing colleges, pharmacy colleges. How many schools of public health do we have? Don't we have to have built capacity in public health? I know the Kerala medical doctors and other professionals are good in public health, but there are a lot of other skills and capacities that we need. I would even think of dual degree programs like MD, PhD. I was so impressed with the digital university that has come up in Kerala, and digital health is going to transform the healthcare in the next 10 to 20 years that we are coming. So I think the health professional has to be trained in multiple areas. We have to have linkage of institutions and public health career pathways supported by internships in government programs. This is something that I've seen globally, that in most of the high income countries, youngsters are posted in ministries of health in programs, so that when they come out, they have a good idea as to how the government machinery works, in addition to being good at their clinical practice. My other suggestion is to create learning labs. What are learning labs? There are about more than 30 medical schools now, and we have a reasonably good health service network. So if you take a sub-district area, let us say a population of 1 million, and then consider it as a learning lab with the Department of Health, with the NCD program, PHC program, with the local self-government, and do implementation research. Because many of the things that are said in NCDs or in mental health are not straightforward, like HIV, TB, malaria, immunization, where there is 20, 30 years of experience. So we have to evolve new models, and learning labs is one way of doing that. Finally, there are good examples that we can leverage and repurpose. If you look at the Kerala State's AIDS Control Society, HIV/AIDS is now on the decline. Why don't we harness that capacity for healthy behavior promotion, for social engagement? We have an Ayush department. They can actually contribute to health promotion and palliative care at both ends of the NCD spectrum. Finally, WHO has got a package called SCORE. And what is SCORE? It's the survey of populations and health risks. We need data, otherwise we are driving blind. And you have seen this beautiful dashboard that Kerala has developed for COVID, which guided the actions. So for NCDs, we need to know who is dying, what is the cause of death, so that we can monitor premature mortality. We have to optimize the health service data, which I think e-health will make a big difference, and a review of program and performance, which is happening, and enable data use for policy action. So this package is known as SCORE, I think, which Kerala should really look at. So with that, I will end my presentation. We can fast forward towards 2030 target of reducing premature mortality. We have to scale up many things. We have to have convergence and have maybe intermediate targets for 2025 and 2028. With that, Dr. Kobragade and the Kerala team, thank you very much for giving me this opportunity. Thank you.
Thank you very much for the message, sir.
Thank you very much. It was an enlightening presentation, and we always hope to see you as a leader who has been a helping hand for the Kerala NCD control program. Thank you very much, sir. Now we move on to the next session, the Kerala Cancer Strategy, which will be presented by Dr. Sadishan. So Dr. Sadishan Balasubramaniam is the Director of Malabar Cancer Center. and who has played an instrumental role in the Kerala cancer strategy as well as the protocol for cancer management. Over to you, sir.
Thank you, Dr. Vipin. Kerala is unique among various states in India because it can boast of its excellent primary healthcare indices and which is comparable to most developed nations. But however, in the case of cancer, it cannot claim the same status. So the government actually wanted to develop a model for distributed decentralized cancer care program in the state so that the out-of-pocket expenditure can be reduced and the resources can be properly allocated and the patients get cancer treatment at appropriate time. So we have a problem in hand. Over past 25 years, there is a significant transition in the incidence of cancer in Kerala. There's almost a 45% increase in the incidence of cancer in Kerala. It's more or less contributed by the demographic transition and which is rolling right now in our state. So we have a population of around 33.4 million and we have an incidence of around 66,000 and the prevalence is over 2 lakhs. And these are the data which has been extrapolated from the data available from Trivandrum population-based cancer registry. So the government set up a committee to look into how we can develop a controlled strategy for cancer with the help of experts from WHO and the experts from 3 cancer centers in Kerala along with the government medical colleges. And few targets were set up and these targets are achievable by 2030. The major things are primary targets which include reduction in the incidence of preventable and also these cancers which can be detected early by around 15% by 2030 and also they improve the survival of various cancers. Cervical cancers by up to 70% and breast cancer up to 65%, colorectal cancers by 50%. And similarly, secondary targets and we aim at the 100% immunization status for hepatitis B and also initiate the vaccination against HPV and at least 55% of patients, the cancer patients should be diagnosed in the early stages and a few more things which have been laid down by the our strategy. So we have developed the strategy and we have to reach up there and a few issues we have identified. One of the major thing is that increasing the cancer care infrastructure. So currently our state has around 25 cancer centers and with around 3 apex cancer centers and 5 comprehensive cancer centers and government medical colleges and in private and also in other areas we have a few cancer centers. But now the number of cancer centers is almost, if you look at the over the decades, almost a 70 to 100% increase in the number of facilities in the state. And another major challenge was restructuring the infrastructure to create a distributed cancer care. And the aim of this one is to reduce the out-of-pocket expenditure and the patients need not have to travel more than 2 hours to get a cancer care facility. And with this idea, we worked on how to restructure the existing facilities. So we put a pyramid and the base of pyramid is constituted by the strongest, robust primary healthcare system and PSCs, FSCs, they will take care of the early detection and also they will take care of the awareness programs. And at the level 3 and where the cancer is detected by the district hospitals and then we have medical colleges and tertiary cancer centers and apex centers to manage the cancer patients. And we had an action plan, we formulated a cancer control board and with the Honorable Health Minister as a chairman and the standard of treatment guidelines were adopted from the NCD and Kerala Cancer Registry, District Cancer Control Program and the Cancer Research Strategy and development of special facilities and meanwhile COVID dropped in, so we have to manage that too. So we adopted the standard treatment guidelines from the National Cancer Grid, and over 200 oncologists from 33 centers and worked together, and we brought it out, and government issued orders on that. Then the Kerala cancer strategy, where all the medical colleges will have HPCR, will have 3 population-based registries on the Regional Cancer Center Trivandrum and Kochi Cancer Center in the Mid-Kerala and Malabar Cancer Center northern part. So the government has issued around 5 orders for the setting up the cancer registry, and we are developing our rules for the rules of operations for the same. Then district cancer control program percolate the entire strategy down to the ground. We have developed that. And the cancer research strategy has been formulated, and as a part of it, with the Kerala Startup Mission and CCRC as incubation center in Ernakulam. Then, and few development and few special facilities in certain cancer centers has been taken up as a resource allocation model. Then COVID-19 different cancer centers adopted a different model by which we manage the COVID patients during this period, and cancer treatment never stopped. So the anticipated results are we'll be able to downstage cancer in early stages, and we'll implement resource stratified management guidelines. And the patient will be able to avail cancer treatment within 2 hours of travel, and it might lower the out-of-pocket expenditure, and the catastrophic cancer health expenditure and financial toxicity could be reduced. So with this strategy in plan, and we are moving it. Thank you very much for patient listening. Thanks.
Next, thank you, sir. Thank you very much for that enlightening speech. Next is is a very big name in the field of public health. I am proud and honored to welcome Dr. Thomas R. Frieden, who was the former president of CDC Atlanta and now the director of Resort to Save Lives. Dr. Tom Frieden worked as an epidemic intelligence service officer assigned by CDC in New York City. And he has worked in various capacities like the Assistant Commissioner of Health and Director of New York City Department of Health and Mental Hygiene. He has also worked as a technical advisor of World Bank, and he had also worked in India for the development of RNTCP program in India. And right now, and he was the director of CDC Atlanta, and now he is the director of the Resort to Save Lives, which is intended to control hypertension and cardiovascular diseases. He had visited to Kerala in 2018 and has shared the dais with the Minister of Health, Kerala. Welcome, Dr. Thomas R. Frieden, to this world of knowledge. Thank you.
Thank you very much, and it's an honor to be with you, at least virtually, in Kerala. I've had the pleasure of traveling to every district in Kerala and have been there many times. One of the many things I missed with this pandemic is the ability to travel and visit with colleagues and share experiences. I will go through some slides here. I've been really interested to hear what my friend Dr. Cherian has to say about NCDs and also the plan for cancer control. And of course, we all know that Kerala is at the forefront of so much in progress in health. So how can it be at the forefront in progress on NCDs? If you look at the global health situation, NCDs account for more than 2/3 of global mortality. More than 40% of the deaths are premature, are under age 70, and 82% occurred in low and middle income countries. And this is very costly, $7 trillion US. This far outweighs any cost of implementation. Every day, NCDs kill more than 1 lakh people around the world and cost $6 billion US in medical costs and economic losses. Now, we looked at what's happening. This red line is what's actually happening. This is the trend, and we have to be frank, it is getting better. Not nearly fast enough, but it's getting better. The problem is the population is increasing. So even though the rate is decreasing, the number of deaths may be stable or increasing in many places. The green line indicates what would have to happen to achieve the global target, which Chairman Verghese mentioned, of the reduction by 1/3 in the risk of cardiovascular death from 4 leading NCDs by 2030. That's merely another 9 years away. And really what this comes down to, if you look at the slope of these curves, is we have to double the pace of improvement. But that's possible. We looked at this carefully, and we wrote this up early last year based on some work that we did for Cherian and others. What would be needed? globally to achieve that 1/3 reduction. Interestingly, tobacco control remains what used to be called captain of all these men of death. Tobacco control globally is the leading cause of death, and the biggest reduction could come from tobacco control. Sodium reduction is next. Prevention and treatment of all cancers that are preventable and treatable will be next. Treatment of hypertension next, and then elimination of artificial trans fat, reduction of air pollution, and reduction of harmful alcohol use. We didn't model reduction of outdoor air pollution because it's increasing rather than decreasing, but that's also critically important. You do all of these things, you get about a 1/3 reduction in death, but we're far from that. Now, in tobacco control, we have the WHO Empower strategy of monitoring the tobacco use and prevention policies, protecting people from tobacco smoke with smoke-free laws, offering help to quit, warning about the dangers of tobacco, enforcing bans on tobacco sponsorship, advertising and promotion, and raising taxes on tobacco. What we see is that the world would have to make a lot more progress than it's making. Same with cancer, same with solid fuel for cooking. What you're seeing is quite interesting. The world actually began making a lot of progress, and it wasn't the world, it was India. The expansion of LPG in India changed the global trend for solid fuel use. And it's possible with this that the world, if it makes this kind of progress, could achieve it. Harmful alcohol progress, no progress in recent years. Sodium consumption, no progress in recent years. Treatment of hypertension, very, very slow progress in recent years, and I'll talk more about that in a minute. Artificial trans fat, no progress in recent years, but a lot of progress recently, and kudos to India, just passed comprehensive trans fat-free India by 2022 strategy. So a lot of credit to India for that, very exciting. And I know Kerala has begun doing work on how do we make sure that gets enforced, so congratulations on that. Now this is the public health impact pyramid. These are the things that affect health, from socioeconomic factors, including education, poverty, access, to contextual changes like smoke-free laws and taxation of tobacco and soda, to long-lasting protective interventions like colon cancer screening and early life interventions, to clinical interventions like control of blood pressure and cholesterol and diabetes, and counseling and education. Generally, the greater the population impact will be lower on this pyramid, and the less impact will be higher. But we have to work at every level in order to have maximum impact. Now, at Resolve to Save Lives, the group that I run, we have a riddle. When does 50 plus 30 plus 0 equal 100? If we can increase global blood pressure control from 14% to 50%, reduce sodium intake by 30%, and eliminate artificial trans fat, globally, together, we can save 30 million lives, or 100 million lives over the next 30 years. Hypertension is the world's leading risk factor for preventable death. It kills more people than any other condition and more than all infectious diseases combined. Every 20 millimeter increase in systolic blood pressure doubles the cardiovascular mortality between ages 35 to 69. And this is so important, and that means we have to do much more with sodium reduction and much more with hypertension treatment. Years ago, we looked at how can we best save lives in healthcare. This was in the US, but the same is true globally. And what's really interesting is that blood pressure, hands down, beats everything else. So if you want to ask the simple question, how do we save the most lives in healthcare? The answer is control blood pressure. Now, this is the global cascade. Globally, there are about 1.4 billion people with elevated blood pressure. Only half of them are aware of it. Maybe less than a little over half are treated, and way under half of that are treated effectively. So what you have is globally 14%, 1 out of 7 or 8 people with blood pressure has it under control. This is really bad. If you think about HIV, 90-90-90, you're aiming for 72%. Here we're at 14% in a disease that kills 7 times more people than HIV, and that's treatable for a tiny fraction of the cost with much simpler medications. How are you doing in Kerala? Well, just about the same as the global average. Only 1 in 8 with hypertension have it under control. This is as per BNJ Open article published year before last. In Kerala, Out of your 33.4 crore people, you've got nearly a crore, 8 million with hypertension, but only 3.6 million, 36 lakh are aware of it. Only 28 lakh are treated. So this is not a large drop-off, but look at this huge drop-off. And I really want to focus, if there's one thing, well, two things. If there are two things I want you to get from my few remarks, the first is that this drop-off is unacceptable. Really, only about a third of the people you're treating are you treating adequately. So your lowest hanging fruit is to reduce the gap between treated and controlled. This could easily double your control rate to 25 or even 30% just by doing a better job treating. You have a problem of what we call treatment inertia in Kerala, and it's quite pronounced. What happens is the patient comes in and a doctor says, oh, come on next month, maybe your blood pressure will come down. You've got a protocol, it's not being followed. If your protocol was followed, this gap would not be there. If you look at blood pressure management, we've looked, if someone comes in and has been diagnosed and their systolic was 160 or their diastolic 100, almost certainly they will require 2 medications, almost certainly. 90% of people will not be controlled without 2 medications. And for those who say, oh, we may get it too low because they may faint or something. No, look at the SPRINT trial. The SPRINT trial is very clear. You get a 27% improvement in survival by controlling to 120 instead of 140. So I'm not saying we should try for 120, but you should definitely overshoot the 140. And you need to address treatment inertia as one of the 2 key priorities for addressing NCDs in 2021 in Kerala. Now, this is by the same article, and look at this, 30% of people in Kerala, adults in Kerala with hypertension. It is your leading risk factor. And even for those with diabetes, it's the leading thing that will cause them to have a stroke, to lose their kidneys, and to die young. Now, we know what hypertension control looks like. Drug and dose specific protocol, you've got that. Quality assured drugs, your supply has been iffy, but you've got that. Team-based care, this is always something we can do more. We saw a remarkable program in Thailand. Thailand has a population of 6 crore, and they have 10 lakh people with who are volunteering in health facilities. In other words, 1 out of 60 people in the entire society is serving as a volunteer with very small amount of stipend in the healthcare facilities, and they're bringing care to patients' doorsteps. It's really a model to be admired and adapted. Patient-centered services. You have to go to 90 and 180-day refills. Look, the poor man or woman is going to be on this treatment for the next 30 years, and you want them coming back every week or 2 weeks or a month. You've got to give them 2, 3, 6 months of medication. You've got to build patient confidence and inform them and address adherence. Systematic monitoring and continuous improvement. You have to look and have an information system that allows you to see and improve rapidly. Primary healthcare is the most needed and most neglected part of our healthcare system. Providing effective hypertension treatment both requires and facilitates establishing effective primary healthcare systems. UHC has to be more than a slogan, and to achieve it, primary healthcare strengthening is absolutely mandatory. Now, here's the second thing that I hope you'll get from this. 3 million deaths annually from excess sodium intake. Reducing population salt content is both effective and saves a lot of money. It can prevent heart attacks and strokes. We've looked around the world, and there are not a lot of success stories in this. There's some. And so the 5 best practices that we've seen. Mandatory front of pack warnings in Chile and elsewhere, very effective at getting industry to reformulate. Low sodium salts, a promotion project in Peru. In India, not only do you consume way too much sodium, as most of the world and we in the US do, but we consume way too little potassium. A low sodium salt containing 15, 20, 30% sodium can make a huge difference because it's a double win. It increases your potassium, it reduces your sodium. Now, for those who are concerned about safety, yes, those who are on certain medications may need to consult their doctor first. Those with kidney failure should not take this medication, but really it's the equivalent for most people's consumption of consuming 1 or 2 bananas a day. So we shouldn't over-medicalize this simple improved product. And it can be used in many cooking items without any change in taste. Food-specific targets. I'd love to see papad and other things with much lower sodium content in India. And there's FSSAI is doing a competition now for better recipes with lower sodium. If we look at Korea, they were able to reduce their sodium substantially just by reformulating one item in their diet, kimchi in their case. Government buying standards. And we've just joined at Resolve with WHO to release public procurement standards. There's no reason in the world why any government should buy food that isn't as per its recommended levels. So there shouldn't be foods high in salt, sugar, or fat in any public distribution program, in any publicly funded program, in any publicly owned property being sold. And that can make a big difference. And then, of course, education. Though we have to think that education, important as it is for many things, unless we change the context, it's not going to work. And we need to change the context with things like the public health, food procurement policy. This is what I mentioned before. These are the locations, basically to eliminate trans fat and sugar-sweetened beverages, reduce sugar, sodium, and fat, increase fruit and vegetables and whole grains, and think about all of these places the government touches: hospitals, schools, childcare, military, prison, parks, community centers, senior programs, retail outlets. There's a lot that government can affect, and we would love to see Kerala show the way on this, because there hasn't been a lot of progress on sodium reduction globally. Trans fat India by 2022, huge progress, a global win. Congratulations and thanks to India. The India Hypertension Control Initiative now supports actually 10 lakh patients in 10 states. Progress on tobacco control is steady, but stronger enforcement is needed and more of a focus on both BDs and smokeless products. GOI has committed to a 30% reduction in salt intake, but no progress that we can see. More action needed on reducing PM 2.5, which is estimated to kill 17 lakh people in India each year. So lots of things to be done differently and better, but lots of best practices and lots of inspiring progress from India. So I wish truly, sincerely, that I were with you in person today, but at least I'm very honored to be with you virtually. So thank you very much.
Thank you very much, sir. It was a very wonderful presentation. You have depicted the picture, global picture of NCDs, as well as you have pointed out the way forward for the Kerala state also. And from the gathering, we have one doubt. Now it is a season of pandemic. The public attention is more towards managing the COVID pandemic. So what all things should be focused to keep the silent pandemics like the NCDs, to keep it controlled during the infectious pandemics and other disasters? So if you could answer that question.
Well, first, we have to recognize that the pandemic tells us the importance of primary care. If we don't have good primary care, we're not going to be able to manage the pandemic, not to detect cases, not to test them, not to vaccinate, not to work. So it's a reminder that we must strengthen primary care. Second, it's a reminder that we must build resilience because people with uncontrolled hypertension, heart disease, lung disease, diabetes are much more likely to die. And the more resilient we are as individuals and communities, the more we can withstand this pandemic and the next one. NCDs continue to be the leading global cause of death. We have to continue. And what we've seen is some very good work in India and elsewhere, expanding things like telemedicine, multi-month prescriptions, other ways to adapt to the context of the pandemic. We need to basically keep up the drumbeat because it's crucial to address NCDs. And we have to speak with all of the leaders at the local, national, international levels to mobilize the will and financing and to address things like treatment inertia, which is making your population in Kerala much more susceptible to heart attack, to stroke, to heart failure, to kidney failure, which makes them more susceptible to pandemics. We have to put things in perspective. Globally, in 2020, well over 2 million people were killed by COVID, and many of those deaths could have been prevented. But 11 million people were killed by hypertension, and most of those deaths could have been prevented. So there's an old saying in the US, we can walk and chew gum at the same time. We can fight the pandemic and improve primary care at the same time, and that will help us fight the pandemic. And improving primary care means addressing treatment inertia. Improving health means addressing high sodium. And these two things, I hope you will take from my few remarks to really look at how you can make dramatic progress and make Kerala, as it has been, a model for the world in improving health in so many ways. Let it be a model in actual outcomes in improving the NCD situation.
So you have talked about managing hypertension and the danger of hypertension becoming another pandemic. So these compound strategies and comprehensive multi-pronged approaches in targeting NCD for achieving the SDGs be more productive than focusing individual diseases like hypertension or diabetes or COPD, or which should we go as a multi-pronged approach?
Well, I think if we just, if I can just go back to a slide for a moment, I'll just share screen one more time. I think first off, we have to understand that what's needed is a comprehensive approach. What's needed is to work at many levels at the same time. And so there is a great deal needed if I'll just share this slide for a minute, think about NCDs. At the base level, poverty, education, healthcare access, all very important. At the changing default levels, tobacco and soda taxes, trans fat elimination, healthy food options, design promoting active walking and bicycling, elimination of lead paint, elimination of trans fat, these reduction in sodium. Some places are looking at a cess on regular salt to subsidize low sodium salt so it's the same or lower cost. As Cherian said, you have to make sure the costs are no higher. So I think on the prevention front, it's very important to be comprehensive. On treatment, I think there's a misconception here. And I think this is important to outline. Can I just finish? That we have to address the problems of the patient. And we have to do that in a systematic way that is accountable for the outcomes. Accountable for outcomes in hypertension, in diabetes, in asthma, in other areas. And we think that hypertension can be a pathfinder for improved primary health care because it's the thing that will save the most lives, including in those with diabetes. And if you address the problems that you have to address with hypertension, following a protocol, which is not being done now, assuring drug supply, working as a team, team-based care, information systems, that can be applied to any and every problem in primary care.
Thank you, sir. Due to the paucity of time, we are stopping your presentation here. On behalf of the Health Department of Kerala and the NCD Control Program, we thank you very much for sparing some time for us. Thank you very much, sir.
Thank you. It's an honor to be with you.
And our Honorable Minister, Shailaja Teacher, Madam is here. She will be speaking to you for a few words for Dr. Cherian and Dr. Tom Frieden. Welcome, Madam. Madam is spearheading the NCD control activities and all the activities under the Health Department. Welcome, Madam. Welcome.
Dear friends, I am very happy to see that we are discussing about a most important challenge the world itself is facing in the health sector, that is non-communicable diseases. Infectious diseases are there, and we are using so many measures to prevent the threat due to the infectious disease, especially COVID-19 during these days. At the same time, we have to address the issue of non-communicable diseases also. The mortality throughout the world, a major part of it is due to the non-communicable diseases like cardiovascular diseases, cancer and pulmonary diseases and diabetes. Kerala is also facing this threat. Comparatively, I think it is a greater threat than other places. Kerala, in much of the health indices, Kerala is in the forefront, and we have so many achievements, very low infant mortality rate and maternal mortality rate, etc. We have very good public health system here, but the non-communicable diseases is rampant here. That is a great threat facing by Kerala in the health sector, especially cancer and diabetes. The chronic obstructive pulmonary diseases are also rampant in Kerala because of the lifestyles and also because of the eating habit that should be changed according to the contemporary world, the situation. Kerala is known as the diabetic capital of our country because the lifestyle has changed a lot. Maybe one part it is an advancement. Kerala have a very good human development index, and we reduced the poverty rate, and we alleviate the poverty alleviation part. Kerala succeed very much, but the lifestyle changed and the physical exercise reduced. That is why we think the diabetes is very rampant in Kerala, and also heart diseases are also here. We have to fight hard with these non-communicable diseases. And according to the Sustainable Development Goals declared by UN, we also declared our aims. One of the most important aim, according to the Sustainable Development Goal, is to reduce the non-communicable diseases, fight against cancer, and also fight against the diabetes, etc. We have formulated a very good cancer control strategy here. Dr. Sadishan Balasubramaniam explained about the cancer control strategy in his talk here. And we are now forming a very good cancer registry, population-based registry. And we are giving importance for the early detection, especially for cervical cancer and oral and breast cancer among women. That is rampant among women here. And through early detection and proper treatment in proper time, we are trying to save human lives, and also we are trying to save human beings from morbidity also. And we succeeded well in that part, but we have to walk a long distance in the fight against cancer, we know it. And also in the case of diabetes also, we are checking or we are detecting earlier who is diabetic. Our ministry, our Honorable Chief Minister asked us, the Health Department, to detect the diabetic even in the early days. And we have a program called Amrutam Arogyam that is led by our Dr. Bipin Gopal, and we are checking the diabetic state throughout the state, and we have a very good result out of that. Now we are controlling the diabetic retinopathy and also the renal failure, etc. And we are checking it very much. And in the case of COPD also, we are adopting some strategy on it. We are converting our primary health center to family health centers, and each primary health center, we have a very good COPD clinic. We are starting, and we started already. And through that part also, we are finding whether any person have this kind of pulmonary diseases. And that part also, that's a great success, we can say so. And we are examining the hypertension also. We are checking the diabetic and diabetes and hypertension above 18 year old, above 18, we are finding out whether they are diabetic or not, and we have a program on that. And through this kind of measures, we are trying to address this great challenge, and we are enthusiastic that Kerala can control this NCD, and also we are insisting physical exercises also. In each and every primary health centers, we are insisting to start either a mini gymnasium or a yoga center to promote the physical exercises. And with the help of local self-government, we are opening some kinds of daycare centers for old ages. And in that daycare center also, we are we decided to have some physical exercise centers there, especially for the old age people. And for children in schools, we are also promoting the physical exercise in school. And for the adolescent stage also, we are promoting some sports activities, etc. in our village. With the help of sports department and also with the help of all other departments, some joint activities are also formulating in our villages, and even in not only in village area but urban area also we are implementing this kind of things. And I think before 2025 we can have a very good result to control the non-communicable diseases, especially cancer and diabetes. And we are working hard and looking forward throughout the world if there any new examples or new method is there. I think after this webinar, we will get some point for action, more successful manner, and we will, after the conclusion of this webinar, we will definitely follow up these kind of discussions and points come out of the discussions. And I am hopeful that we can move forward containing these non-communicable diseases also to save human beings, human lives. Thank you, everybody.
Thank you very much, ma'am. You have given us an overview of policy, in fact, what are the initiatives of the government to control the NCD. Now, in fact, we are eagerly waiting, in fact, what Kerala has been doing in past few years. So now I request my colleagues, Dr. Bipin Gopal, Dr. Kiran, Dr. Naveen, Dr. Matthew, and Dr. Satishan to come forward for the next session to tell all of us about, one by one, our initiatives, what we have been taking regarding hypertension and diabetes, COPD, mental health illnesses, and also cancer care. So, Dr. Bipin Gopal, please welcome.
Presentation. Okay. Thank you, respected madam, respected sir. So on behalf of the NCD division, Government of Kerala, I'm presenting the webinar series. I'm opening it here, Meet the SDG, Meet the NCD. So this is the Kerala profile. We have a population of 33.39 million with a population density of 859 and a high literacy of 93% with a low MMR of 42 and a low IMR of 8 and a life expectancy of 75 years, which is a very rosy picture, which is often lauded by the globe, UN itself. But on the other side of the coin, we are on the highest epidemiological transition zone with a rampant urbanization and a changing lifestyle. The prevalence of hypertension has gone up. Now it is between 32 and 38%. And the prevalence of diabetes, we are often called as the diabetic capital of India. The prevalence of diabetes is between 19% and 35% according to the recent study. And the overweight and obesity of men and women are often above Punjab, which is the second highest in India. And this has led to the rise in renal diseases. We now have 84 dialysis units under the Kerala Health Services Department alone. The number of, as Madam told, the COPD cases are going up. The cancer cases are going up. We are above the national average for cancer. The stroke cases, especially the young stroke cases, are going up. The coronary artery diseases are going up. The number of heart attack deaths in India, in Kerala, is actually going up. So to battle that, the wheel of motion, the Kerala Health, the NCD cell and the health department is a well-oiled machinery with the hub and spokes, the stroke units, the COPD units, the dialysis units, the chemotherapy units, the retinopathy clinics, the diabetic foot clinics and CCU. We are all set to combat the menace of NCDs. So these are the SDGs for NCDs, which we have developed at our state. Even though we have a UN SDG, even though we have a national NCD, this is the SDG which we have selected. So we will meet the SDG first. The first one is halt the increase in prevalence of raised BP by 30 to 40%. The second one is the halt rise in prevalence of diabetes mellitus by 18 to 20%. The third one is 30% relative reduction in tobacco use, which we have already achieved. And fourth one is 20% relative rise in people consuming 5 servings of fruits and vegetables, which we are yet to achieve. And 5 is 10% relative reduction in mean intake of salt, which we have actually started with the reduction of trans fat and salt. We had initiated many steps with the help of food safety department. And the sixth one is 50% increase in drug therapy for myocardial infarction and stroke, which we have very well done, which I will be presenting in the later slides. And the seventh one is 5% reduction in alcohol use, but in that area we have gone down. And eighth one is 10% reduction in insufficient physical activity, which, as Minister has told, we are doing many things to achieve that. And the ninth one is the management of COPD by 50% reduction in household use of solid fuels. So these are the footprints of the NCD. We have screened in the last 3 years over 1 crore 24 lakhs people. We have diagnosed over 9 lakhs patients, diabetic patients, 13 lakhs hypertension patients. We have NCD clinics in all the PHCs, all the CHCs, all the sub-centers and district and sub-district level hospitals. We have exclusive staff like dietitians, the staff nurses, the data entry operators, doctors, and the health workers. We have the Schwarz clinics in 312 institutions, stroke clinics in 9 district hospitals, retinopathy clinics in 168 hospitals, and cancer clinics in 24 hospitals. So regarding the SDG 1 and 2, it is the India Hypertension Control Initiative, IHCA, which is spearheaded for managing diabetes and hypertension. It is a multidisciplinary approach with the help of National Institute of Epidemiology, Chennai, the Ministry of Health and Family Welfare, Government of India, WHO India, and WHO India Office, Vital Strategies, and the Department of Health and Family Welfare, where the burden of hypertension in Kerala is 1 in 3 among Kerala is having hypertension, and in every 100 hypertensive patients, only 44 are aware of their status, only 37 are on treatment, only 13 have their blood pressure under control. That is a very worrying factor. Regarding diabetes also, we have 1 in 5 adults with diabetes. We have among the 100 diabetic patients, 44 of the TB patients are diabetic, only 16 have their RBS under control. So the control rates of the diabetes and hypertension was very low, and that's why we came up with the IHCA program, where there is a structured program where we mark every patient with a treatment card and we evaluate at the end of every month. And we have nearly 3 lakhs patients under this program, with 2 lakhs 94 patients with hypertension and 1 lakh 67,000 patients with diabetes. So this is the monthly and cumulative registrations. I'm not going to it, but this is a very significant slide. From 16%, from 13%, our control rates have risen to 38.5%. That's a remarkable thing under the IHCA program. And we also have found out that 37% of the people are not responding to the treatment. So that is area of concern, and 24.5% are defaulters. So this is the area that we have to manage, tackle. So after the treatment, after diagnosis, we now treat the patients with and the complications also. We have a drug protocol for hypertension and diabetes. We procure all kinds of drugs, including insulin, the tissue plasminogen activator, reteplase, and the drugs are given free of cost for all BPL patients and elderly patients, and medicine for 1 month is issued. And we also manage the complications. We don't start with the we don't stop with the primary diseases. We also manage the complications. We have diabetic retinopathy clinics with the use of non-mydriatic cameras in 168 family health centers. We have diabetic foot clinics with biothiometers, handheld Dopplers in the district and sub-district level hospitals. We have dialysis unit, 84 dialysis units, hemodialysis units, and 3 peritoneal dialysis units. We have also set up stroke units in the district hospitals, and this is for the first time that we have thrombolized nearly 146 patients, and 94% of the patients have left the hospital without any residual paralysis. And we have 14 CCUs, 5 cath labs functioning in the state. And we also have a center of excellence for management of diabetes at GH Ernakulam. And we also have a program for the management of COPD. And this is also one of the flagship program under the Ardhram mission, where a treatment and management of COPD was taken up for the first time in public health arena around the globe, we say. So we have provided pulse oximeter, we have provided oxygen concentrators, we have provided spirometers for diagnosis of COPD and asthma. And we have actually diagnosed more than 19,000 COPD patients and 12,000 asthma patients. And we are giving drugs, aerosols, which are very costly, free of cost for every patient. And the complementary services along with the SWAS program that we are getting is that we have smoking cessation services. We have 6.7% of patients who quit smoking after the counseling, and 13,000 people got pulmonary rehabilitation, and the number of TB diagnoses made during this screening is 10,000. 1,058. So this program is also going on very well. And these are some of the activities which we are doing for the primordial career activities. We have a school NCD program. We have health arena for checking of BMI in every schools, which we are doing with the help of VHSC, the NSS units. We have the college health programs. Madam has inaugurated 2 college health programs, 1 cricket match and 1 football match, 1 in Trivandrum and 1 in Kozhikode. We have the school yoga program. We have the program for community health, and we have also program for the workplace intervention, and that is our DHS office having the yoga program. And we have also started open gyms in all the districts. 3 or 5 gyms per district we have earmarked funds in the last year. And without tobacco control, we cannot achieve NCD control. So it is the SDG goal number 3. The GATS2 showed a decline in prevalence of tobacco use from 21% to 12%. And we have already achieved the goals. And with association of the tobacco control NSS units, we have banned gutka, e-cigarettes and all. And this is my last slide. We had many challenges like floods, which has submerged the living of the people with everything lost. We have pandemics here, but our NCD control program did not leave anyone. So we went to their homes, we went to their doorstep, we distributed drugs, we kept the people healthy, and we could maintain the NCD control here. And for these activities, the United Nations Interagency Task Force has awarded the state government, our minister, last year in 2020. So I welcome Dr. Kiran for continuing the mental health program. Thank you.
Thank you, sir. Good evening, all. And it's said that the evolution of the mental health care can be best described by 5 C's. That is confinement in the early centuries, to the concept of caring in the 1800s, to concept of curing by the 19th century, to the advent of medicines in 1950, to community mental health in 1960s. And with this aim of community mental health, the National Mental Health Program was started in 1982 by the Government of India. And the first DMHP, that is District Mental Health Program, which is a unit of National Mental Health Program, was started in 1996. The first DMHP in Kerala was started in 1999 in Tirunelveli district. And by 2017-18, we could start mental health program in all the districts of Kerala, and Kerala is one of the first states to achieve this feat of having mental health program in all the districts. Now, the mental health program conducts 283 monthly clinics in the state, mostly at the CHC level, and caters to the needs of about 45,000 patients monthly. The activities include the clinics,
which has already mentioned as mostly in the CHC level, mental health training to mainly primary care doctors and paramedical staff, health workers, etc. Targeted interventions, which will be dealt in the later slides in detail, IEC activities, and community-based rehabilitation activities. The SDGs in mental health were set in 2016-17, and 7 of them were there. The early detection of emotional and behavioral problems in children, to reduce the high suicide rate in the state, to reduce morbidity due to depression, to reduce treatment gap, to reduce treatment dropouts, integration of mental health in primary care, and rehabilitation of mentally ill. And different strategies, different targeted interventions were devised to achieve these goals. And the most notable among them was Sambhurna Manasikarogyam, and the most successful was also Sambhurna Manasikarogyam. And it will be dealt in detail here. And WHO has recommended delivery of mental health services through primary care system, as the burden of mental health disorders is 10 to 12% of general population. And with this aim in mind, the Sambhurna Manasikarogyam was implemented. It was first in Trivandrum district and later on scaled up to the entire state under Ardhra mission in 2017-18. The main objectives are to find the undetected case burden, that is to reduce the treatment gap, integration of the newly detected cases to a family healthcare system, ensuring reducing treatment dropouts, increased awareness, and community-based rehabilitation. The protocol in a nutshell, the program is implemented in the concerned FHC, that is family healthcare system. Technical support and supervision is provided by the DMHP. Training to the grassroots level workers, that is ASHAs, sensitization of the elected representatives, the Arogya Sena members and health workers, house visits by the ASHAs. And house visits, the ASHAs, while doing the house visits, they do the screening and cases are detected. They were referring to the camp, which is conducted by the DMHP in the concerned FHC. Also, mental health awareness classes are conducted in the schools, government institutions, ICDs and Kudumbashree units in the concerned Grama Panchayat. The camp is followed by 2 review camps by the DMHP itself, and stable cases are referred to they are transferred to the concerned medical officer of the FHC, who will conduct weekly or monthly camps or clinics in the concerned FHC thereafter. Here the patients will be getting regular treatment from here on in the concerned FHC itself. And follow plans are done involving the health workers and the LSG elected representatives for rehabilitation units, including Pagal Vidugal or daycare centers in the community or in the panchayats itself. Completed in 366 FHCs till date, that is 366 Grama Panchayats. 8,334 ASHAs were trained as part of the program. 18,046 new cases were detected, and a total of 24,964 cases were given treatment as part of the program, and they are still getting treatment in their concerned FHCs or the nearest FHC. Increased mental health awareness, involvement of ASHAs, health workers and LSG elected representatives, and integration of mental health into primary care as part of this system or a part of Sambhurna Manasikarogyam have helped to increase the total number of cases under treatment in DMHP from 9,486 in 2016-17 to 44,351 in 2020-21. That is a 5-fold increase in the number of cases. There's a diagnostic split up of the cases we have treated in Sambhurna Manasikarogyam. As we go through it, we can see that mild mental illnesses account for a bulk of the cases, which shows the effectiveness of the screening by ASHAs. Highlights of the program, as mentioned earlier, it's highly cost effective. It's just 30,000 rupees per panchayat. It comes to about just 30,000 rupees per panchayat for a year. LSG members become more involved, but the most notable among them, ASHAs become the grassroots level workers of mental health in each panchayat. So they are approached by people for clearing doubts, for seeking modes of treatment for new cases, etc. They also help to ensure that regular follow-ups and reduce the treatment dropouts. The second program we have implemented, Honorable Minister actually inaugurated the program Ashwasam, that is depression management in primary care. Here, the health workers and staff nurses are trained in screening of depression, because depression alone accounts to about 5 to 10% of the general morbidity in general population. So, an exclusive program for depression screening was devised, and health workers and staff nurses are trained in screening using PHQ-9 questionnaire. Doctors are trained in diagnosis and treatment of depression in the primary care itself. And staff nurses of the FHC are trained in psychological first aid and psychosocial intervention. Here the difference is that the entire program is being run by the FHC staff or the primary healthcare staff itself, unlike the Sambhurna Manasikaram where the camps are done by the mental health program. Referral protocol for the cases to be sent by DMHP is also been set. High-risk case list is to be prepared in each FHC or Gram Panchayat under the program, which includes patients under palliative care, caregivers, those with a substance abuse and their family members, history of deliberate self-harm, family members of those committed suicides, NCD patients, and those with recent life events. This screening is done at the sub-center level. Ashwasa under Ashwasa program, 55,727 persons have been screened till date, of which 10,000 were found to be positive. Pharmacotherapy was started in the FHC itself for 6,349 and psychosocial intervention were given for 11,503. 2,087 cases were referred to the DMHP for higher management. Another program, another targeted intervention was Amma Manasa, that is maternal and infant mental health services. It was implemented with to address the following, mainly the high suicide rate of 6.95% of the total MMR, especially in 2017-18, and increasing incidence of depression, anxiety, and other psychosocial issues we have been seeing in the antenatal and post-delivery period. And under the Amma program, these illnesses, psychosocial issues are screened in the first trimester, second trimester, and third trimester of the antenatal period, and again 3 times during the post-delivery period. That is the 6th week, 14th week, and 9th month of the post-delivery period. A training is given for mainly for JPHNs, staff nurses, primary care doctors, gynecologists, and pediatricians, and awareness is given for ASHAs. Till date, 7,060 block level staff and 16,355 ASHAs have been trained as part of implementing the Amma Manas program. Jeevaraksha program, that is exclusively for suicide prevention. That is in order to reduce the suicide rate in the state, the program was implemented. And it mainly focuses on training on community gatekeepers, that is elected representatives, doctors, health workers, police personnel, teachers, religious leaders, etc. who the people who are in distress tend to meet regularly. They are given training on suicide prevention, especially on warning signs of suicide and psychological first aid. And increasing awareness on media guidelines of suicide reporting is given as part of the program. Highest group for depressive disorders are screened at sub-center level by JPH and JHI and interventions given if needed. This is the functional level of mental health program at the different levels, field level, sub-center level, FHC and CHC levels. As you can see, the different targeted interventions have their own different set of works in all levels. And that's a referral system here. And functional level, that is includes case detection, management, referral, and default tracking in mental health. Last but not the least, the disaster management aspect. The psychosocial support has been an essential component of mental health or any disaster. Psychosocial support has been an essential component of disaster management activities since 2017. And we have seen it in Oki 2007, Oki cyclone in 2017, Nipah outbreak in 2018, in Kerala floods in 2018, whereby in which we were, ASHAs have been given, ASHAs and mental health workers have been given mental health counseling services to 2.3 lakh people during that time. Landslides at Kavalapara and Puthamala in 2019 was another instance, and we have seen it recently in Corona or COVID-19 outbreak in 2020, where 7.12 million calls have been made till date. Of course, the mode of psychosocial intervention have changed to telecounseling services now, and as part of the program it is being done. And definitely the extension of the mental health services to the community level and involvement of the grassroots level workers in mental health definitely helped in achieving these SDGs, and of course in the psychosocial support we have done so far. Thank you. Now inviting Dr. Naveen, District Program Manager, Calicut, for continuing the presentation.
Respected dignitaries and my dear colleagues, good evening all. First of all, I would like to thank you for giving me such a wonderful opportunity to present in such a platform about the implementation of our NCD programs at field level. In the last two presentations, our state nodal officers covered the two major programs at state level, and here I'm going to show some pictures about the programs in the way it is being carried out at the district level and at field level. And we are in the journey towards for achieving our SDG goals, and definitely at field level and grassroots level, our staff are working very hard for the same. And these are some pictures in primordial and primary prevention of our non-communicable diseases, campaigning about our healthy diets. And the second picture is, it's a plot in Republic Parade held in Calicut district. And in each and every opportunity, we are trying to give something about NCD control programs as a message to the public. These are some pictures of programs, Poshan Ma, about nutritional programs at a field level. And the second one is our program Vibjior, and it's a sports tournaments ensuring participation from our college students, and it was a big success. In both years, we could conduct the programs very successful. And we are conducting routine classes to school children in different offices and other institutions in the name of Arogya Jwala. And our department promote open gyms all over the state, and at district level, open gyms are opened, and in the next phase, in all LSJs, open gyms are being promoted. And these are two examples. The first picture is from our family health center and a small gym, and second one is from our sub-district hospital, and it is very useful for both public and for our staff. And yoga instructors were posted, and in our family health centers, yoga classes are being conducted in a routine way. And according to government, they promote all exercises, and government is going to make a cycling track in Ernakulam. Like in that way, we are trying to put a behavioral change in our community, and it is the most important part in the primordial prevention of non-communicable diseases. And all our activities are coming under Ardram Janakiya campaign. It was a wonderful program by our health department, and the major area of focus were healthy food, exercise and activities, de-addiction, cleanliness and waste, preventive and promotive health, and improving health-seeking behavior. And we are conducting all IACs and all campaigns under the umbrella of Ardram Janakiya campaign, which was successfully held across the state. And in the secondary prevention of NCDs, early diagnosis and treatment are the major parts of secondary prevention. And the important part is population-based screening, and it's being done by our NCD clinics. And we insist screening of all patients coming to hospital for diabetes above 30 years and for hypertension above 18 years. And we have NCD clinics in all of our major hospitals, and NCD clinics are being conducted in all our FSCs and sub-centers, and the identified cases are treated at various levels. This is ideal patient flow on all days. All patients about 18 years screen for BP, blood pressure, irrespective of their purpose of visit, and about 30 years for diabetes. And coming to diagnostics, in the past 5 years, our health sector has gained a lot in the diagnostic area. And these are pictures from our peripheral hospitals. We have CT scan facilities in our peripheral hospitals, and CCUs and treadmill tests like that for identifying cardiac diseases in district hospitals. And coming to treatment, in the past 5 years, there is a drastic change in the treatment sector also. And these are pictures of cath lab and CCU from district hospital and stroke unit from district hospital. And we are also focusing on tele-ICU system for improving the outcome of our ICUs. And it's an example of a PPP model. And it's an exact example for strategic purchasing. And coming to the treatment of complications, it's a Nayanamridam. And through this, from our family health centers, trained staff will take photos of retina through non-Medriatic gamma cameras, and by tele-system, we will get results within 20 minutes. And in most of the FSCs, it is being implemented. And these are dialysis units and CAPD units in the state of Kerala. Nearly 44 dialysis units are functional now as a part of our Ardhram project, and continuous ambulatory peritoneal dialysis units are also being implemented. This is the pictures of Schwarz clinics at the family health center level. And coming to TB NCD collaboration, and it's a bidirectional screening with a 4-symptom seal. It's identifying diabetes or TB in patients with TB and diabetes, and we are giving insulin pens for TB diabetes patients. Coming to tobacco control, enforcement of CODPA Act, and ban of vodka and e-cigarettes, yellow line campaign in educational institutions. These are some IACs about tobacco control, and it's being done under National Tobacco Control Program. And finally, we are towards digitalization, and eHealth NCD module is ready, and NCD registration, screening, surveillance, and hospital management system is ready in eHealth module, and it is going to be started all over the state. These are some activities of our district mental health program, Sambhurna Manasika Arogya Kendram and Amma Manasu. It's a very wonderful program which is being implemented at grassroots levels. And in the occasions of disaster, mental health activities are very much useful for the public. Okay, I am inviting my colleague Dr. Matthews Nambeli to discuss about the structure of implementation of the NCDs. Thank you.
Good evening, everyone. I am here to present the implementation of NCD activities, the structural framework for the implementation of NCD activities in Kerala. As you all know, Kerala has a very good decentralized governance system, which gives us good opportunity to implement all the activities with community participation. Our base unit is the ward. Each ward has a population of about 1,500. Kerala has more than 20,000 wards like this. Each ward is having a team. The team consists of the ward member, who is the elected representative of that ward, ASHA worker, who is selected by the panchayat and trained by the health system, Anganwadi teacher looking after the mother and children of that ward. And the Kudumbasri system, which is a very efficient system in Kerala, its aim is poverty alleviation through women empowerment, and it has good network in all the wards, and it is supported by a good system of volunteers. There are many social and political activists in each ward, and also representatives of various charitable organizations, residents associations, etc. And all these form a group which can influence the common people in that ward in the control of NCD. So this group mainly involved in three various spheres. One is the lifestyle modification, that's the primary prevention activity, lifestyle modification, activities against tobacco, activities against alcohol, then diet modification, include more fruits in diet, activity promotion, etc. Then the second one is they spread the message of the warning signs of different diseases and the importance of early detection of diseases. So people are motivated for undergoing screening programs to detect the diseases early. And third is they gives good psychosocial support for all the people with the diseases. They have a line list of diabetes, people with diabetes, people with hypertension, people with psychiatric problems, seizure disorders, bedridden people, homebound people, elderly people. This team has a line list, and they gives the much needed psychosocial support for all these people with diseases. And we have a good system of palliative care also, in which these volunteers go to the patients, go to the houses of bedridden patients and sits there and gives the support mainly in the psychosocial area. Then the JHA and JPHN offer sub-centers, gives the technical support for these activities in the wards. Each sub-center has covers about 3 to 4 wards, and these JHA and JPHNs are trained in the health system, and they can give the technical support for all these activities in the ward. And they also conduct special clinics in the sub-centers like NCD clinics for the screening of NCDs, and also gives training through the sub-centers. Next level is the family health center level. There the people are motivated from the ward for the screening and all those things. And in the family health center level, all the FSCs in Kerala has facilities for early detection of diabetes, hypertension, and lab facilities, and also for early detection of cancer. And also they provide counseling on diet and lifestyle modification for those referred from the wards. And also the basic medicines. We are providing all the basic NCD medicines through the PSC. If there is shortage in medicines, the local state governments through their funds support the program, and we can ensure the supply of NCD medicines in PSC. Then there is the referral service from the PSC to the higher centers, and also back referral from higher centers. Once patient is diagnosed from higher centers, they are diagnosed back to the PSC and followed up from there. And also have a good home care system to provide nurses and doctors care at home for the bedbound and homebound patients, and also for providing comfort devices like waterbed, airbed, wheelchair, walkers and crutches for the needy patients. And also coordination of training and awareness generation for the public is also being done from the FHC level. Now, next level is the community health center. There we have introduced a special program in view of the NCD called Chronic Disease Management Unit, which comprises the activities of this NCD program, mental health program, elderly program, palliative care program at a nodal center. And it has a team of trained medical officer, 2 trained staff nurses, and a trained physiotherapists. And they have the special nurses care, special doctor care, physiotherapy, and also inpatient and all services are provided. And they are also giving costly medicines and comfort devices through the CSC. And monthly specialty clinics like mental health clinic are also being done from community health centers. Then the next level is the sub-district hospital, where we have the specialist doctor consultation, inpatient care, imaging services for even for cancer early detection, mammogram, etc. there, dialysis facilities there. Then hub and spoke model lab facilities. There we are having FNAC, so facilities for FNAC, pap smear, and also the histopathology hub and spoke facilities there. Then there is a team in every sub-district to link with the periphery. Then the district hospital has the super specialty services, And it is also the district note for the professional training of all these programs for the doctors and nurses. And also there is a team for each activity in district hospital, like for the NPCDs program, for the palliative care program, elderly program, mental health program, SWAS program, district early intervention program, blindness control, deafness control, oral health. All these programs are a team in district hospital, and they coordinate and monitor the activities being done in the field. Similar activities are also there in the medical colleges, but the connection with the field is not that much as it is in district hospital, and we are trying to improve the field linkage with the medical colleges also. Thank you.
Yeah. We thank all the panelists and who had given their review on how NCD is being controlled in Kerala. Now we move on to panel discussion on the strategies and control of Kerala, strategies and control of cancer in Kerala. And the moderator for the session is Dr. Moni Kuriakos, and he is the director of Kushi Cancer Research Center, and he is an eminent head and neck surgeon and a researcher. And I request Dr. Moni Kuriakos to take over the proceedings. Thank you.
Dr. Sadishan, thank you. So we're going to have a panel discussion, as Dr. Sadishan mentioned, about strategies to control cancer in the state of Kerala. You have heard from Honorable Minister that the cancer incidence is increasing, and the strategy to control the cancer also been described by the Honorable Minister as well as Dr. Sadishan. And we're going to hear from Mr. Safrullah, the IAS former collector of Ernakulam, about one of the strategies which was implemented in Ernakulam district. But for this panel, one thing we have to understand is that cancer incidence in Kerala is doubling every 15 years. And then this is almost, the incidence is almost double that of the rest of the country. But the good thing is that, should I pause for a minute or shall we continue? Dr. Rekha, okay. So let's pause for a minute and we'll ask Dr. Rekha to give her presentation. So Dr. Rekha is the director of RCC Trivandrum. She's going to talk about some of the strategies. You heard a few minutes ago from Dr. Sadishan about the Kerala cancer control strategy. So she's going to outline that strategy. Let's invite Dr. Rekha. Dr. Rekha, please continue.
Yes.
Thank you.
Good evening, ma'am. Good evening, all.
Please continue, madam. Yes.
Yeah, please. I'm sharing my. Well, my talk is regarding evolution of cancer care in Kerala. Evolution of cancer care in Kerala is invariably linked to 4 decades of cancer care activities spearheaded by the Regional Cancer Center Trivandrum. We are located in the southernmost district of Trivandrum, and we started by 1981. Cancer treatment was delivered by radiotherapy departments of government medical colleges. RCC Trivandrum was established in 81 by Government of India, and we developed into a center of excellence in cancer treatment and research. Malabar Cancer Center was established in 2001 and Cochin Cancer Center in 2016. As part of decentralization, there was creation of medical and surgical oncology posts in various medical colleges, and chemotherapy and teletherapy facilities was established under the DHS. We cannot move forward without acknowledging the visionary Dr. Professor M. Krishnan Nair, who was the founder director of RCC from 81 to 83. He established RCC Trivandrum as one of the largest comprehensive cancer centers in India and put Kerala in the world map for cancer control programs. He was actually the expert advisory panel of WHO on cancer care for more than a decade. And he was a member of the expert group that drew up the National Cancer Control Plan of India, the NCCP. Kerala was always in the forefront of cancer control activities, and NCCP program from 84 to 96, RCC played a pivotal role in that. In 1984 itself, we established our first early cancer detection center in Ernakulam, starting with the pap smear screening program. 85-86, Cancer Care for Life program involving society was launched by RCC. A 10-year action plan for cancer control in Kerala was launched in 1988 by RCC. And as part of establishing district cancer control programs throughout the country as part of the NCCP in 11 districts in India, we established the DCCP in Ernakulam in 1992. It was one of the first 11 districts in India where this program was successfully implemented. Similar programs, DCCPs, were again run in districts of Kollam and Kannur by establishing early cancer detection centers in these districts. Finally, we now have the Kerala Cancer Control Strategy and the Standard Treatment Guidelines introduced in 2019. The NCCP introduced in 84-96 by Government of India. The Kerala model was accepted by the WHO. And RCC's role in cancer care during these decades, we served as, and in fact, Kerala served as a model for other states in cancer control. We established the first community oncology department in the country in 85 to provide preventive oncology services. And there was establishment of pain control networking in as early as 1992. First oral morphine manufacturing unit was started in 91 in RCC, and we established the first pediatric oncology division in 1982 in the country, first in the country. And this unique insurance scheme to support poor cancer patients was started in 86, and it was the opening to patients was stopped in 14, but the program is still continuing. These are the early cancer detection centers that was established by RCC in 5 districts from 1984 to 2000. They were created to create awareness in the community for primary cancer prevention activities, coordinate and provide early detection services, follow-up care of treated cancer patients, as well as pain and palliative care services. These are being well run even now. Important contributions in the past include, we ran United Nations Population Fund Assisted Comprehensive Control Program in selected taluks of Kasaragod, Kannur and Kannur districts in 2000 to 2002, focusing on oral, breast and cervical cancers. There was another Trivandrum Corporation Cancer Control Program that ran for nearly 10 years from 2002 to 2012, funded by the Trivandrum Municipal Corporation and run with the help of government health system, including ASHA workers, Anganwadi workers, and Kudumbashree groups. There is also a population-based women cancer screening program in the rural parts of Trivandrum districts, and ran with the help of the Kerala government health services in the primary health centers in the locality from 2010 to 2012. These are the unique interventions done to disseminate cancer control. RCC could declare 1 lakh tobacco-free homes in the entire state of Kerala in 93-94 through trained Scouts masters in the schools. This led to, we received the international acclaim and was awarded the World No Tobacco Award from the WHO. School-based interventions for cancer control in the district of Pathanamthitta and Trivandrum districts in 2009 to 10 and 2014 to 15 were also conducted. women empowerment for cancer control using Kudumbasri volunteers was done in the year 2009-2017 in the district of Pathanamthitta. Awareness against substance abuse program among model residential schools were done under the Scheduled Department from 2019 and is continuing even now. The School of Colposcopy was established in RCC 1996 till 2005. It is funded by the IARC to train doctors and nurses in colposcopy and to train master trainers in colposcopy. This was a mobile oncology unit set up in 2010 at a cost of over 1 crore. That's still being run, and it was a joint venture of Regional Cancer Center Trivandrum, Malabar Cancer Care Society Kannur, CDAC Trivandrum, ISRO Bangalore, and Government Department of Communication and Information Technology, Government of India. We established and tested low-cost screening methods for cervical cancer, and there were 2 major randomized community-based studies in oral and breast cancer screening in Trivandrum district. This resulted in cost-effective screening for reducing oral cancer mortality using oral visual inspection, and we were able to downstage breast cancer through clinical breast examination. All these were done in collaboration and funding from the IARC through Dr. Shankar Narayanan, the then head of the Screening, Early Detection and Cervical Prevention Group and Special Advisor to DG at the IARC. Sir is one of our faculty today. This resulted in a landmark paper in the Lancet that came in 2005. We also produced this oral atlas prepared by in collaboration with WHO and IARC. It's still available free of cost in the IARC website. Just the role of cancer registry in cancer care, funded totally by ICMR, Government of India. We have the HPCR started in 1982 and is covering 4 lakhs patients. Or PBCR again started in 2006 covering Trivandrum and Kollam districts, and now the other southern districts of Pathanamthitta and Alappuzha and Kottayam from 2018 onwards. We have 1 lakh patient data regarding cancer incidence and 60,000 patient data regarding mortality. This is already published, including WHO publications. Second is cancer surveillance programs, pattern of care survival, care and survival based on HBCR data. More than 50,000 patient data is being currently done with breast, cervical cancer, head and neck cancers since 2006. Again, it is extended to gynec, childhood and hematological cancers in 2018. We also have a population-based cancer survival studies, including breast cancer, cervix, head and neck cancers in Trivandrum and Kollam district, covering more than 30,000 patients. All this is funded by the ICMR. We have several epidemiological studies going on along, again, funded all by the ICMR. Now, all this crystallized, all these 4 decades of our cancer care and control activities in Kerala state crystallized in the form of a Kerala cancer control strategy. This broad strategy was prepared and submitted by RCC to the government in 2016. WHO got involved in February 2017. We prepared the final draft along with the WHO office in India. We sent for inputs we got from directors of other cancer centers. The final meeting in 2018 involving all cancer specialists in the state. This was brought out as a document in 2018, Kerala Cancer Control Strategy. Several RCC initiatives also served as models in cancer control in Kerala, recognized by the WHO. We established the first community oncology department in the country and also developed these and tested these low-cost screening strategies for common cancers like oral, breast, and cervix. So we have an excellent pain and palliative care network in the state, and a telemedicine platform was introduced in 2004. And it's running, and it helped us during the COVID times to link with all the peripheral centers in the district hospital and taluk hospitals in the state, along with our ACDCs. We developed the cancer control strategy for the state with timelines and developed the training manuals for early detection of common cancers. A few words regarding cancer care during COVID times, the Kerala model. This is the distribution of new patient registration in 2019-20. You can see that patients are coming from Kasaragod down through all the districts, and from Northern Kerala alone, we have 20% of our registrations from Northern Kerala alone during during the pre-COVID times. So during the COVID treatment, we had no guidelines, no protocols. And there was a complete shutdown in March, April. There was no public transport. Patients were finding it difficult to treat RCC. Finding lodging in and around RCC was a problem because all hotels and lodges were shut down. And on the treatment front also, we had serious concerns regarding drugs, personal protection kits, storage of blood products. Healthcare workers were finding it difficult to commute to RCC, and near total shutdown in the coming month. We did only emergency service. Emergency surgeries continued. Ongoing radiations were not affected at all. And chemotherapy for oncological emergencies were continued. So we realized that cancer care cannot be deferred indefinitely quite early in the phase. And so we went into a triaging mode. All our cases were grouped as active cases and follow-up cases. Within the active cases, we had 3 groups that were first that needed RCC care, second that could be treated in the peripheral centers, third that needed palliative care. Under the follow-up cases, we had routine cases as well as special follow-up cases. So a virtual OPD was set up for all the follow-up cases, and this was run successfully and is continuing even now. So now RCC and the Department of Health Services Kerala already had a tie-up as an ongoing program. We are treating doctors in health service for the last so many years in the field of early diagnosis, post-treatment, follow-up care, palliative care, and basics of chemotherapy. So we made up a list of all the hospitals, district and taluk hospitals under the DHS from north to the South Kerala, and 21 centers were identified throughout Kerala, all the districts. And we went into team building mode. Doctors from RCC and doctors from all the 21 peripheral centers came together. We had virtual meetings, and the plan was to make basic cancer care available at these centers. And patients on active treatment would be informed, and they will be reporting at designated dates to any of these centers nearest to their homes during the lockdown period. Data was also transferred. The clinical summary was made in each case in RCC, and it was sent to all the centers so that any patient given on their given dates could approach any of these centers and get their treatment. So this was highly successful. In Kerala, in Kerala alone, we actually gave these clinical summary notes to the peripheral centers in more than 2,600 cases. And for Tamil Nadu, it was around 500 cases. And we are thankful to Director of Health Services, Dr. Sarita and Dr. Bipin Gopal for collaborating in this very unique, challenging endeavor for patient care, for dissemination of patient care in all the districts of Kerala. And again, drug delivery was a problem. So most of the drugs were available in the district peripheral centers, but again, additional drugs were made available by the Kerala Medical Services Corporation Limited. Still, there is a drug shortage. What we did was the Kerala Fire and Rescue Services came to the rescue of RCC. So they collected the patients' prescriptions through WhatsApp and directly, and they will report to RCC early in the morning. And our consultants will go through all these lists, get the drugs from the pharmacy, and will be handed over to the fire force personnel. And oral medications were given to the patient's doorsteps, and injections and other drugs were also given to the nearby peripheral centers by the fire force personnel. And we also could maintain the cold chain wherever required. Most of these drugs were given free of cost to welfare scheme patients and for poor patients from our Poor Patients Fund. And only patients who could afford were paying money directly to RCC or the fire service. This was again a very unique experiment that was successfully done during the COVID times. Now we are continuing the district dissemination through the district centers even now. This treatment modality is being continued even now. The impact of lockdown on RCC's cancer cases, registrations, new registrations total OPD numbers, total surgeries, and daycare chemos fell down to 50%. When you compare it with the 3 months of March, April, May in 2019 and during the COVID time in 2020. Only radiotherapy services were given, only a 26.5% reduction in radiotherapy services actually happened, and most of the planned radiotherapy services were given during the lockdown period as well. Similarly, with the Tamil Nadu patients of RCC, we had opened a dialogue with the DM of Kanyakumari district, and all patients of RCC patients from Tamil Nadu were given treatment in Kanyakumari Medical College. But those needing RCC care, we put these patients on 7-day quarantine, and when tested negative, we took them for active treatment. That is how we managed nearly 500 Tamil Nadu patients during the lockdown period. To conclude, cancer care need not be deferred during COVID times. COVID care and cancer can go hand in hand. Decentralization of cancer care is the way forward. Apex centers should focus on specialized care. All basic oncology care can be done at peripheral centers, including early diagnosis, basic cancer treatments, follow-up, and palliation. We have to strengthen and upgrade our peripheral centers, and we have to resort to unconventional means to deal with unconventional situations.
Thank you.
Thank you for the patient hearing.
Thank you, madam. Thank you for narrating the cancer story, control story for the last 4 decades, and RCC leading that effort even now. Thank you, madam. Please be online. We will come to the panel discussion. We'll get your thoughts. Let me now invite Mr. K. Mohammed Safirullah. He is the project director of eHealth Mission of State of Kerala, and he was the former collector of Ernakulam district. Sir, over to you, sir. And Mr. Safirullah is going to speak to us about Ernakulam District Cancer Control Program. Over to you, sir.
Honorable Minister, Srimati Shailaja Teacher, Honorable Secretary, Dr. Rajan Khobragade, distinguished dignitaries, friends. For the next 10 to 15 minutes, I would be happy to share the experiences of Ernakulam District Cancer Control Program, how it was launched and what was the way ahead, which was what has been done, and some of the results which we would like to share. I'll be presenting the work of the Cochin Cancer Research Center, the Department of Health Services, and the National Health Mission. The background, as we know, that cancer is one of the major priority issues for the government of Kerala, and more than 70% of all cancer deaths occur in low and middle income areas and countries. Though the countries have lower incidence, but these countries have higher mortality when compared to the other countries. In this context, if cancer is detected at the initial contact with the health system and is followed up for successful diagnosis, then it is identified world over that the cancer fatality rate can be brought much down. And as I said, Kerala has a very important priority to this particular area. And Kerala is known for higher than national average in the areas of social and health indicators. And this was one area which government of Kerala wanted to look into. And during the year 2018-19, the Kerala government started and launched the Kerala Cancer Control Strategy, based on which there was a clear roadmap on how to address this particular specific issue. The primary targets of the 2030 vision of Kerala Cancer Strategy were twofold. One is to reduce the incidence rates of cancer amenable for prevention and earlier detection, that is cervix and oral and breast, up to 15% by the next decade, that is 2030, and improve the 5-year cancer survival rate to 70% for cervix, 65% for breast cancer, 60% for oral, and 50% for colorectal cancers by the next decade. There are many secondary targets. I would just like to go through a couple of them. One is reduce the smoking rate, the chewing rate, which was also touched on by the earlier speakers. The most important thing I would like to say is to create awareness among the public on how do we address the cancer and start identifying it at the early stage. The district cancer control program of the Ernakulam district, the primary targets were to empower the primary healthcare services for early detection. The secondary objectives were many: to create awareness, introduce the risk reduction strategies, capacity building, and various the navigation, working out on the navigation strategies. The methods, I would like to dwell a couple of minutes on the strategies. One is to, the strategies which was done is, one is to look at the cancer literacy program itself among the public and also among the health workers. Create an awareness of early warning signals. As we all know that earlier the identification, the increased chances of the cure. Empower specialists in diagnosis procedure, prompt referral and timely initiation of treatment, and integrate the surveillance of cancer identification with the palliative care network where the relief can be given. The cycle of the entire work is, it starts at the primary health center, the FSC level integration at the PSC FSC level, then the biopsy confirmation at the taluk or district hospital level, and the community cancer care nurses getting involved later, and the cancer care centers taking care of them at the further stage. And continue the monitoring after the evaluation, take the rectification measures. We had taken a bottom-up approach in the district cancer control program strategy. We had taken I hope I am audible.
Yes, sir. We are audible. Your slides are clear, sir.
Yeah, thank you.
5 minutes, sir.
Yeah, thank you. Yeah, I'll try to finish in 4-5 minutes. We had followed up stakeholder sensitization, where we started the bottom-up approach involving the local, representatives, and also sensitizing the workers. The public awareness was done using the local languages, spreading pamphlets, conducting training sessions. The activities at various levels, the Panchayat ward level, at the CCRC and Taluk level. As we know, the Cochin Cancer Research Center, the OP wing of it, was started by Government of Kerala in 2016 in the month of November. And we have a lot of valuable resources, and CCRC was pivoting this particular initiative. The patient flow, I have briefly touched on earlier. I will not dwell on it because I am aware that there is a panel discussion following it, which wherein Dr. Moni Kuriakose would also look into it. I would like to conclude with the results. That is, we were able to train about 700 healthcare workers, about 80,000 members of the public. About 600 plus biopsies were performed over 6 months, out of which 59 were malignant and 8 pre-malignant. The median age of diagnosis was 60, 55% were female, 48% of the total cancer diagnosis was oral cancer, which was a major revelation. We were able to bring down the availability of biopsy, the median time for availability of the biopsy report, and about 86% were linked to the community palliative care network. These are the results. And the major, results I would say was the success in the way in which the general public participation increased. The month-wise thing. I would like to go to the conclusion now. The conclusion, the couple of points I would like to talk about is we have the primary care and the cancer care services have to be integrated. And we feel that the early cancer care detection using the existing infrastructure and manpower of health department is possible. And after the identification of the result, further research is also required for reducing the time period of diagnosis and improving the outcomes. The lessons learned, just the first 2 points I'd like to dwell on. One is the ownership should be, I feel, with the local level, guided at the central level by the state government. The training and infrastructure creation is sufficient for the initial stage, but has to be built and linked with various other institutions at a later stage. The way forward, this is my last slide for today, is we have to scale up. What I understand, the government is trying to scale it up in 3 zones and with 8 centers. and also in the district level cancer pathology and radiology services have to be worked up, and develop a digital platform what equivalent to eSanjeevani, I believe, and link the diagnosis with cancer registry. I would like to acknowledge the team who were instrumental in carrying out this work, and I am just presenting what actually is their work, and thank you everyone for the opportunity. Thank you. Have a good day.
Thank you, sir. Really appreciate you narrating the story about District Cancer Control Program, a strategy really in action. Kindly be online. We want your inputs during the panel discussion. So the panel discussion consists of real global experts from around the globe. We have Dr. Anil De Cruz, President of UICC, as well as former Director of Tata Hospital, Mumbai. Dr. Richard Sullivan, Professor of Cancer and Global Health, King's Institute of Cancer Policy and Co-Director of Conflict and Health Research Group, University of London. Dr. Shankar Narayanan, former Director of Cancer Early Detection and Prevention of IARC, WHO, France. You heard from Dr. Rekha that some of the original work was started by him in the state. Dr. Arni Purushottam, Director of King's Health Partners Integrated Cancer Control Center, University of London, and Dr. N.V. Pillai, Professor of Oncology, Thomas Jefferson University, Philadelphia. We brought these experts from around the globe for one reason, because in the cancer journey, we are not alone. They have walked the path much ahead of us, and some of the population, cancer is the leading cause of death, and we can learn from their experience. So that's the reason for bringing these experts together. My first question is to Professor Sullivan. Professor Sullivan, my question is, if you look at Kerala for several reasons is a central state. Other states follow our trend. And in fact, if you look at the numbers, our number is almost double that of the rest of the India. And if you continue the same trajectory, we're going to reach your number. And we want to learn from that. Professor Sullivan, please comment. How can we learn from your experience in UK or rest of the world?
Moni and Honourable Minister, ladies and gentlemen, thank you very much indeed. I want to say what a great pleasure it is to be invited to say a few words on really lessons around the epidemiological transition, as we call it, from high-income countries. And when I say lessons, they're more warnings, I suspect, than lessons. Many high-income countries have had significant issues in their cancer transitions. I'm going to begin by outlining maybe, I think, the 6 major principles that I think we've learned from the transitions in high-income countries. The first one really is the matter of exactly that, principles. We know from the work of people like Thomas Piketty and particularly his work around a fantastic book called Capital in the 21st Century, that it does make a difference whether you focus on inequalities, in other words, the greater good, or whether you focus on specific delivery of services. And it's quite clear from a lot of countries in high income settings, if you don't deal with inequalities up front, what you will see is incredible changes in outcomes across your population. The second thing is the political economy of cancer. This is again work that's been done in a lot of high-income countries now. It really mixes together the fiscal policy with economic policy. And the first learning, I think, from high-income countries is you cannot substitute for public health care expenditure. And it's not to say that private sector is not important. It's just it is not substitutional for proper expenditure on your public health services. The second thought is funding the workforce is probably the rate limiting step. And I'll say a little bit more about that in a moment. And the third point is that user fees are highly regressive. The more you can drive down out-of-pocket expenditure for cancer care, the better your outcomes and the more affordable your overall care system will be. So let me just return to the healthcare workforce. This is a problem that's been known about since the 1960s, and it's known as the cost disease, Baumol's cost disease. And Bill Baumol was a major economist in this area. And what he said was simply this, that as we increase the workforce, you're supposed to see improvements in productivity due to technologies. But in healthcare, we don't see that. And the reason is, of course, that technologies are additive to our workforces. So the salaries of the workforces increase, the numbers of doctors and nurses increase in order to deal with the increasing cancer burden, but productivity, in a sense, doesn't get any better. So the real cost burden that we learned about in high-income countries is that you have to be prepared for substantial investment in your people over decades. And actually, capital expenditure on hospitals and equipment is a relatively simple thing. What really matters is funding people. And if that's one take-home message I've got from the high-income lessons, it's this problem of the Beaumont effect. The other thing which is related to that is, as I mentioned, technologies. The other thing we learned in high-income countries is you have to embed technologies as part of pathways and models of care. One of the greatest deficits we've seen, I think, in high-income countries is when the technologies, be they pharmaceutical, radiotherapeutic, the beloved robots in surgery, if they're not embedded into proper models and pathways of care and they're properly managed, what you see is runaway costs without any improvement in outcomes. And this is essentially a reduction in the value of the system overall. And ourselves and a lot of Indian collaborators have published very extensively on this. And it speaks to the need to manage the introduction of new technologies, be those drugs, radiotherapeutic, or whatever. The next point we've learned from high-income countries is the need to plan services and systems based on evidence. A lot of national cancer control plans are not evidence-based. A lot of them have not done the required work around workforce planning in particular, in terms of distribution of care, how patients are going to access those based on patient pathways. And again, there are lots of very good tools now available. And high-income countries that failed to base their national cancer control plans on evidence tend again to have very poor outcomes relative to the expenditure. And then the final 2 points I want to make are really around cancer as a development issue. And I guess this is where sort of India broadly and Kerala is. The focus on progressive universalism, number one. Number two, ensuring that the health and welfare political economies are aligned. In other words, again, ensuring good value. And thirdly, improving cancer services that are affordable and equitable really requires foundational investments. In other words, in general surgery, pathology, general medicine. So it's not just a matter of focusing on cancer, I mean, that's almost the pinnacle of your health systems. It's about also supporting all the other district hospitals. And last by no means least, we learned to our cost, I think, and this was the work of John Kingdom and other luminaries, that if you don't align politics with policies and your solutions all together, the systems will fall over at some point. And certainly looking around high-income countries, those that have managed to align their politics with their policies, with the solutions, are the ones that have successfully delivered good cancer outcomes, which are affordable and, generally speaking, equitable across the populations. But I leave you with one final, perhaps, warning from high-income countries, is we are seeing inequalities grow now for a variety of reasons. And that's probably because, going back to the first principles, we're ignoring some of the inequality issues that are actually pushing our societies apart. So I'll stop there on my opening remarks and hand back to the chair. Thank you very much indeed.
Thank you, Richard, for your comments. I will take your note on this point. Technology is additive, doesn't really improve the productivity. We'll come to that topic in a minute. But let me get the views of Anil De Cruz. Dr. Cruz, you are the president of UICC. What's your thoughts on controlling a global control of cancer control around the globe, particularly low-income countries? Over to you, Dr. De Cruz.
Yeah, good evening, Moni, and to the leadership that's organized this meeting. Thanks for having me here. Richard, always wonderful to hear you speak. Hello to you and Ani. We've not met or caught up in a long time. I just take away from what Richard said, and he made a strong case for equity, the economical aspects of cancer control and cancer care, and kept the high-income countries as a model. But when I look at it, and this is going to be very, very simple and easy, when you look at the incidence of cancers, not only in our country, but globally as well, a large proportion are preventable cancers. Look at our tobacco-related burden. It's just so high, and that's the world over. 18% of all cancers, lung cancers, 11% deaths, lung cancers, and 90% of them are tobacco-related. I would say that while we do look at the equity of treatment, the economics, I think a lot needs to be done on the preventive and the early detection stages as well. I was surprised to hear that though there's a lot of economic allocation in high-income countries for treatment and the robots and the manpower, precious little is allocated towards prevention. So I think I would make a strong point towards prevention. And if you talk specifically to our country, I think our primary healthcare system needs to be strengthened in a big way. So if we only look at prevention, we'll see the effects, but we'll see the effects a long time later. So I would advocate a diagonal approach to this. We strengthen our primary healthcare system, and we also strengthen the treatment and the vertical silos of specialized care. That's manpower, the technology, the infrastructure to treat these patients. And I think that's really what we need in this country. Cervical cancer, oral cancer, really preventable cancers, large chunk of our tumors, breast cancer, again, a major problem, all detected in late stage. If we could shift that needle towards early stage, I think we would make an impact. So I'd make a strong case for prevention and early detection. Back to you, Moni.
Thank you, Anil. Really appreciate your comments. Your thoughts on integrating primary healthcare and cancer care is wonderful thoughts. I think we'll get the thoughts of Ms. Safrullah also in a minute. Let me come to Ani. Ani, Richard mentioned that the machine cannot replace humans. So our challenge is going to be humans. So what's your thought about expanding human resources and in a scalable fashion, not just one too much in a scalable fashion? Over to you, Ani.
Thank you very much for the kind invitation to this panel and for sharing thoughts. I mean, one of the major challenges for healthcare providers is the human resource required to diagnose and treat patients with cancer. There's a paucity of radiologists, histopathologists, nuclear medicine specialists, surgical oncologists, medical and radiation oncologists, palliative care physicians, specialist nurses, psychologists, and psycho-oncologists. Just for an example, India has 30% of the surgical, medical, and radiation oncologists it requires to care for its patient population. And we all know it takes years to train a cancer specialist workforce. So I think the first thing is we do need a strategic future 10-year plan to increase the specialist cancer workforce by expanding the number of training positions across the country. In addition, we need to find further solutions to this problem, which require innovation and radical thought. Examples of these are upskill and cross-skill professionals, develop extended roles for nurses and allied healthcare professionals, develop a clinical oncologist training program similar to the UK. So in the UK, you can train in both radiation and medical oncology. So our radiation oncologists treat patients as medical oncologists. So that immediately increases the workforce. Develop new roles such as patient navigators. These could be recent school leavers. Develop new roles such as physician assistants, and these could be recent graduates. Ensure greater use of technology, for example, teleradiology and telepathology. And most importantly, all of this needs to be underpinned by adopting continuous education through a blended learning approach. Thank you, Moni.
Thank you, Ani. We'll come to you in a minute. Let me get Dr. Shankar's view. Shankar sir is one of the authorities when it comes to early detection. He has established cancer early detection programs throughout the world as part of IARC chair. And in fact, he, along with the guidance of Krishnan Nair sir, started the very cancer control program in our state. Shankar sir, how do we think about developing a comprehensive cancer early detection program throughout the state? If you look back your experience from the past, how do you, if you're going to start the whole thing again, how will you start, sir? Over to you, sir.
Thank you very much, Moni, Madam Minister of Health, and respected Secretary of Health and colleagues. Thank you for the kind invitation. I mean, time and again, the previous speakers were pointing out that a significant proportion of cancer cases in Kerala, despite its high literacy and highly developed health services as compared to the rest of the country, are presenting in advanced stages. If you go by specifics, if you look into almost 60 to 70% of the cases present in stage 3. Stage 3 is the model presentation of cancer cases in Kerala, where 5-year survival is usually less than 40% for some of the treatable cancers like breast cancer, whereas it is much lower for head and neck cancers and around 40% for cervix cancer and colorectal cancer. So what we, when we consider early detection, to my mind, 2 approaches come in. One is early diagnosis, which is detecting cancers early in symptomatic people. And the second approach is screening, where you systematically apply early detection tests for essentially asymptomatic people to develop preclinical or pre-symptomatic cancer. Screening programs require considerable investments in health services, resources, providers, and a healthcare capacity which should be able to take care of the diagnostic expectations and management. But on the other hand, early diagnosis is probably the most suitable program for many low-income countries, as well as for Kerala, for the simple reason that within the existing health services provided to improve awareness of the population and empower the primary healthcare practitioners, both in private and public sector, and improve the primary healthcare services and the infrastructure within the primary health services with early diagnostics infrastructure. This is something, and then building up a referral pathway, where to refer, can help considerably in early detection of some of the very common cancers like the oral cancer, breast cancer, colorectal cancer, cervix cancer, and which are major cancers in our state. And having said that, the issue is fundamentally reorienting primary care practitioners, because in the undergraduate medical curriculum or in the postgraduate curriculum, there is very little on cancer early detection and cancer control. That means in-service reorientation has a major role. And of course, you have done it in Ernakulam district. And Dr. Babu Matthew, when he was the professor of preventive oncology at the Regional Cancer Center in Trivandrum, under the aegis of Dr. Krishnaya, my respected professor, has done quite a lot of activity in reorienting our primary care practitioners. And one of the major bottlenecks is when you say early detection, early diagnosis, essentially it doesn't stop with the early diagnosis tests we do, like the oral visual inspection, or a clinical breast examination, or a fecal vocal blood testing. I strongly urge to introduce FOBT in Kerala primary health centers, or visual inspection with acetic acid, or HPV testing. It has to be followed by diagnostic investigations. That means nowadays people crowd the secondary care and tertiary care centers for diagnostic investigations, which should not be the case. So that means the primary health center should have a minimum infrastructure like digital x-rays, a diagnostic mammography equipment, and a colposcopy service, and management of precancerous lesions of the cervix and things like that. The ability to direct biopsies, both punch biopsies, incision and excision biopsies, and all of those has to be inbuilt within the primary health center, so that the crowding of the people in higher centers could be avoided. And then with very careful monitoring of the stage shift in tertiary care centers and through population-based cancer registries. And that means, again, and another important point, subsidizing early diagnosis services. Because what happens is, now there is a lot of subsidy You know, in welfare programs, you treat people under subsidized schemes. Poor patients are taken care of. The middle income group suffers because there is a major problem with our healthcare financing, where a large section of the middle income people suffer very badly because there is nothing to support them. And similarly, in the case of early diagnosis investigations, subsidizing early diagnostic investigations is very critical to improve the compliance of the people for their response, the health system response for their symptoms. And then in the case of Kerala, as like my professor and Dr. Krishna as well as Dr. Bhavamati did, you know, the establishing early cancer detection centers, beefing up with an excellent infrastructure, and inbuilding telepathology and telemedicine services, teleimaging services, you know, which can considerably reduce footfalls in the higher levels of health service, is something we should look forward to. You know, increasing the inputs of digital technologies, electronic communications, and awareness creation measures have a major role now in future in cancer early detection. And I would make a plea here, please introduce fecal vocal blood testing in primary health centers, you know, targeting 50 to 69-year-old people, because colorectal cancer follows breast cancer. Breast cancer is increasing at a rate of 3% per annum. You will see in about 10 to 15 years our colorectal cancers, and then similarly our endometrial cancers coming up. But these are some of the points I wanted to emphasize. Thank you, Moni.
Thank you, sir. Really appreciate your thoughts and comments. Now let me bring in Professor M.V. Pillai. Sir, you have brought in a lot of innovative ideas to the state, for example, the Virology Institute and so on. But if you look at the elephant in the room, for starting a very large intervention program, it is going to be the cost. No question about that. And what really drives the cost is the new drugs, new technology, and so on. That to change that, we need innovation, homegrown innovation. Is it possible? And if it is possible, what's the roadmap, sir? Your thoughts, sir.
Good morning, and I really appreciate your inviting me for this excellent scientific conference. Due to the time constraint, let me just get into the answer point. Moni suggested an excellent topic. Is it possible to realize the Make in India dream, which is the new India's dream project, especially after the collapse, I wouldn't say collapse, but irrelevance of globalization, and the world is now turning into a multipolar society. Yes, I think this is the ideal time for us to step into this field and have a Make India project. Now, the next point is whether this Make India project, can it give us a sustainable, affordable, quality program for the whole of India, and of course for Kerala, that's what we're talking about. That is conditional, because the reason I'm saying conditionally, because of the investment included. And here's where the private-public participation becomes extremely important. And I'm going to quote you a couple of examples. Now, the private-public participation is an idea which has come to India recently, but we have a classic example of how this system can have positive impact in cancer care. Look at the Tata Memorial Center in Bombay. Tata's and the government of India, Atomic Energy, join hands, and we have an excellent world-class center of excellence. Tatas have gone to the Calcutta, and they have set up another Tata Medical Center. And recently, Tatas came to Kerala and gave us an extra pair of hands to set up our COVID care center in Kasaragod. So that's the right thing to do, a right move in the right direction for the right cause. We need more of this public-private participation in cancer care. Now, it doesn't stop there. Moni asked me to comment on the Biopolis in Singapore and also the Stanford's Biodan Center. Both these centers are excellent, a concept which we need to nurture and develop in India for a variety of reasons. As you all know, that the Biopolis in Singapore has been designed as an ecosystem to bring in researchers from basic science, applied biology, and clinical side, industry, all into a single campus. And this is open to international businesses, and Novartis has a big presence there. Singapore government has so far pumped in something like $2 billion, not million, $2 billion into this project. Same is the case with the Stanford Bioden Center. And of course, their advantage is they're close to the Silicon Valley. There are foundations and contributions and endowments coming from industries. India's future will depend on such a system, either creating a biopolis-like system in Kerala or anywhere in India, or building up something like a Bioden Center in Stanford in partnership with companies like Tata. It's absolutely important because investment is the key here. If you look at India's GDP, we have so far been spending about 1.6% of our GDP for healthcare. Compare this to United States, where we are spending here like 17%, and UK spends about 10%. So we need to put in more money into the health sector. And I'm glad that the present government is planning to have 3% of the GDP put into the healthcare sector before 2022. Even that is not sufficient for the type of dream that we are nurturing now, like a metropolis, the biopolis type of setup in India. Now, once we have established that kind of an investment, I think then we can look at how we can sustain quality cancer care at affordable. So it's a conditional statement. It becomes affordable only when we have established such centers, such ecosystem, which can harbor researchers, industry, commercial agents, clinicians, health policy advisors, all working under the same campus. Now, Kerala is ideally poised to do that for a variety of reasons. We all know about the high literacy. More importantly, we know about the mobile health literacy. You can see the vast number of people carry a mobile phone, and they are reachable and they use it all the time. Now, here is something which United States is concerned about now in the digital pathology system. There is something called a digital divide. Unless you provide broad bandwidth, many of these images cannot be transmitted. So those who can afford the bandwidth included telephone system or mobile system will have an advantage of getting their care transmitted through major medical center. So our insurance policies, including our Karunya Pathadi or Ayush Pathadi, should include payment for the provision of a broadband connectivity to our patients. Now, Kerala is ideal because we already have a technopark where monoclonal antibody research is going on. Phase 1, phase 2 clinical trials are being coordinated. We have a life science park where we established the Institute of Advanced Virology, and more companies are moving in very soon. We have a Department of Science and Technology. We have the Rajiv Gandhi Center for Biotechnology. We have an excellent regional cancer center, 2 excellent government cancer centers too. If we can bring them all together under one roof, partner with industries, invite international companies for partnership, just like what's happening in Singapore's Biopolis or Stanford's Biocenter, then we are in the right direction to realize our goal of accomplishing affordable, high quality, comprehensive cancer care. That's all I have to say.
Thank you, sir. Let me now bring back Professor Sullivan as well as Dr. Shankar. As Professor Sullivan, in your talk, the word which resonated was equitable care. And Dr. Shankar mentioned about the middle class which are losing out in that care. And he also pitched for the cost or covering the cost for early detection. Now, not in a NHS model, outside NHS model, how can you bring in an equitable cancer care? Is there anything exists anywhere in the world, sir?
So many years ago, I had the pleasure of working with Professor K.N. Raj in the early 2000s. And of course, you know, K.N. Raj is the godfather of the Kerala model for equitable growth. And one of the things we used to discuss was how health actually can fit into the idea of the Kerala model, because that was his economic theories were all around land reforms, poverty reduction, educational access and child welfare. And it was interesting because This was a fantastic model for applying in lots of emerging economies, but the problem was that it didn't really take into account the rise of non-communicable diseases and the fact that many countries were going to go through this double burden problem, where there were still infectious diseases, child and maternal mortality, and at the same time, the rising burden of the non-communicable diseases. And one of the discussions we used to have together was exactly what, in a sense, Sankar and also what Anil was talking about, was the connectivity between the community and the primary care and the fantastic growing tertiary and secondary care centres. Because you can have the best technology in the world, the best doctors in the world, sitting there waiting for patients, but if they're turning up with stage 3 and 4 disease, you're never going to see improvement in outcomes. And of course, we know that actually the cost of treating stage 3 and 4 is vastly more than treating early stage cancer. So there was this question of it was more than just getting patients to present earlier, because one would assume when taking like Kerala, as education goes up, as literacy is improving year on year, things should improve in terms of stage of presentation. But the reality is there needs to be a different economic model around providing that community connection between the patient in the community and these fantastic and growing services in Kerala. And I don't have an easy answer to that. I mean, I'll go to the expert in this, Sankar, about how to do this. But from an economic perspective, that is where the missing piece seems to be at the moment.
I have my secretary in the audience, so hopefully I'll ask him at the end of the discussion. So let me ask Dr. Shankar sir. Yeah, I was always enticed by your comment about the Thailand model, that one board model. Can you narrate us, can we learn anything from that? Sir.
Thank you, Moni. I think, let us face the truth. The sector of the population which loses out heavily is the middle income group people, because they have to face everything by out-of-pocket coverage. And it is very difficult, and many families go bankrupt. Let us face it. And then in the welfare scheme patients also, the welfare schemes are highly inadequate. And even if you look into the Ayushman Bharat reimbursement schemes, if a hospital follows this, there will be heavy loss. So first of all, we have to be generous in the way, in the case of welfare schemes, and we have to bring in universal health insurance, the universal health care. Thailand achieved this in 11 years. And I have very closely followed the Thai universal healthcare scheme right from the beginning, because I had a very long association with Thailand. And when the former Prime Minister, Thaksin Shinawatra, introduced a 25 baht scheme, anybody can pay 25 baht, which is like $1, which will allow seamless access into health service. Somebody comes with diarrhea, 25 baht. Somebody comes with a breast lump, 25 baht, which will take through diagnostic investigation, staging, surgery, chemotherapy, radiotherapy, follow-up care, and everything. Then finally, after 3 or 4 years, they found, accounting this 25 baht is becoming a major problem. So they scrapped off the one-time payment of 25 baht. And the governments very cleverly made a healthcare fund. About 11% of the population is government employees. They pay around some $350 per family. And about another 14-15% is private healthcare, private sector employees, who pay around something like $170. And the Thai government, for the rest of the 75% of the people, through a taxation system, pays around $70 to $75, which all goes to a central fund, which subsidizes the entire treatment for a variety of illnesses, including renal transplantation. At the moment, the Thai system is a little stressed because politicians were adding on some of the things, but it is still holding on. And I have seen the same system evolving in Morocco. Morocco is an exceptional African country where exactly the same pattern is followed. And then there is subsidized healthcare for everyone. And another thing which improves compliance to treatment, in addition to healthcare financing, appropriate healthcare financing, is the organization of dormitory services. Because people have to still travel for cancer care. And accommodation is very difficult. You cannot put them everywhere. Somebody coming for radiotherapy cannot be admitted in. So the dormitory service, Morocco has built in what is called the Maison de Vie. That means the house of life. with every cancer treatment facility, public facility in the country, where people will come and stay for a protracted course of radiotherapy, chemotherapy, and things like that, which has substantially improved the participation of people, compliance of people for treatment. You know, we always look to Western countries for models, but most of the workable models are not in the West for us, but it is in some of the middle income countries which have taken a very key role in rolling out health services which are far better, which is more equitable access, as Richard says, for their own people. So we have to learn from these models.
Thank you, sir. We definitely going to learn a lot from your global experience. Now, another point I want to cover to address is what Anil mentioned some time back about strengthening primary healthcare and integrating primary healthcare with cancer care. I want Arnie's thoughts also on that. See, now if you look at how cancer care and the rest of the NCD looks like two parallel streams. One cancer stream going on, another one is the rest of the NCDs as well as other system of care. Anil, your thoughts? What's your thoughts on integrating? How can you bring them together? I also want Arnie to comment on, maybe right from the training, how we can integrate the whole thing together. Anil, first your thoughts, please.
I agree with everything that's been said, what Richard said, what Arnie said, what Dr. Shankar said. It sounds good when we sit across meetings like that, improve the infrastructure, put in more money, improve manpower. If we look back, but I want to be a little pragmatic because I've seen this from the ringside seat when I was at Tata's. I also see it now from the corporate world. I see it across various countries now in my position at UICC. Let's take our country, for example. We've suddenly ramped up the number of people that we train. And this is in response to a comment that Arnie made. So even at the Tata Hospital, we suddenly, from 2 training seats, we made it 24. Without much change in the infrastructure. I just want to caution people that do it, but do it with quality. It's not the number. We must never forget quality, and I think that's something. Otherwise, 10 years down the line, we will have problems. Quickly responding to Shankar's on the Ayushman Bharat, I agree that the total funding is inadequate, but I think it's a very strong and a very positive first step by our government. It will improve with time, but I always make a plea, and I don't know who mentioned this. One of the speakers today mentioned a part of that Ayushman Bharat, you can only avail of it if a part of that is factored into prevention, that you have to come for your regular checkups through the years, and then God forbid you do get a cancer, you would be entitled to the Ayushman Bharat. So I make a very, very strong case for that. And to your specific question about integrating primary healthcare, NCDs, I mean, that's a no-brainer. I'll say it has to be done. We can't see cancer in isolation. And I think the NCD Alliance is a strong testimony to the fact that you have to integrate policy between cardiac, between the diabetes, within your respiratory, and within cancer, because they have, most of them have the same risk factors. And I think they are, you see them all intermingled together. The case I would make is the hub and spoke kind of model. I think Ani may be in a better position to say it. It was thought of, conceived in the state of Assam, where you have different levels of care. You have the primary care, and then you have the diagnostic centers. You go up to centers, then can do basic cancer work, and then you have the apex centers. And I just think that's very, very important, and it must come in our country. Remember, we talk of various models. We forget that we are inundated by huge numbers and not so adequate resources. So we have to think out of the box and not just ape anything that comes from the West or anything else. But Moni, again, a strong plea that we have to strengthen primary healthcare. Results seen many, many years later, but I'm a strong proponent of that.
Thank you, Anil. Ani, your comments. You're muted, Ani. You're muted.
Thank you, Anil. I couldn't agree with you more. So let me take a couple of those points. The first is the primary healthcare system. One of the biggest strengths in the UK is the primary healthcare network that we have. And the strong integration between primary healthcare system and the secondary tertiary care system. So our patients and the public see their GPs first, and the GPs are superbly trained based on the patient need, then refer the patient up to the secondary tertiary care facility. So, and it is a very, very strong network. I mean, you can go into the England primary healthcare system database and you can immediately see what's happening across the country in terms of the patients that are being seen at different practices. And that's one way of quality of the care that patients get. We in our hospital in Guy's Cancer, it was about 10 years ago, we decided we would have a different model of care for our patients. We didn't want all our patients coming into the cancer center in central London, and we felt that a number of these patients could be treated closer to their local area in the southeast of London. So coming to the hub and spoke system, we set up a spoke for the Guy's Cancer Center in a place called Sidcup, which is about 1.5 hours away from central London. And patients would attend there, but importantly here, we upskilled and cross-skilled other professionals. We had extended roles for the nurse practitioners. We had the receptionists trained up to help with the imaging. Very rarely does a doctor actually have to go out to the center. The patients are all done and treated remotely, but if they do need to come to the main cancer center, then we arrange for them to come to the center. When I was working with the Tata Trust, we used this model in Assam to set up the hub and spoke system, as Anil was indicating, at different levels. So we had a level 1, level 2, level 3. Level 3 was outpatient care in remote areas. Level 2 was closer to the cities where you would treat the common cancers, but the specialist care was done in comprehensive cancer centers in a level 1 center. And that is the model that is currently being implemented in Assam, and is a very good model I would recommend in terms of taking things forward. And it allows the patient to be treated closer to home. You still have the skills of the entire workforce from the center as well as from the community. And I cannot stress enough about the primary healthcare system. That is the anchor for our patient population in the United Kingdom.
Thank you, Ani. We are really running out of the time, so I wish we could continue this discussion for a longer period. Really want to thank, on behalf of the government of Kerala, I really want to thank all of you for joining us from different parts of the world. Thank you all for your comments and valuable suggestions. Thank you.
Thanks, Moni. Congratulations on your effort.
Bye-bye. Thank you.
Now we are coming to the final session of the day, and achieving SDG related to cancer, the challenges. It's my privilege and pride to introduce Professor Rajendra Badwe, and he's a living legend in oncology in India right now. And he has been a role model for many of the oncologists. And he's the director of Tata Medical Center and President Head of the Department of Surgical Oncology in TMH. And he has been a strong proponent of low-cost treatment facilities and with high output. And he has brought in many practice-changing researches and results in oncology. And the country has duly recognized him, and he was conferred Padma Shri by President of India in 2007. And I request Professor Badwe to take over the session. Thank you.
Thank you very much, Dr. Satheeshan. Can I have my slides? 1 minute. Let me just share the screen. Okay, are my slides visible? Yeah, okay. So towards the Sustainable Development Goals, controlling diseases and making health an important priority, What I'll try and cover quickly is action for cancer. And before I get on to it, let's quickly understand what's the magnitude of problem that we see here in India compared to the rest of the world. So I put the numbers in proper context, and you will find that in US and UK, per 100,000 per year incidence is close to 300 and 300 and above, whereas that in urban India is 100, in semi-urban it is 60 to 75, and in rural it is 40 to 50. Not that we are missing cancers in rural India, because we do have 4 centers where we have house-to-house survey performed annually to understand if there is anybody who has cancer or anybody would have died of cancer, with a very, very rigorous verbal autopsy procedure, which has been proven to be 80–85% accurate. So there isn't much of cancer there. The problem here is that although these numbers of 100, 60 and 40 have remained relatively constant for the last almost 15 years, every decade about 10% transition happens, that a rural locale becomes semi-urban or a semi-urban locale becomes urban, and that much increase in incidence happens within a year or two. And these differences are essentially because of the prostate, lung and colon cancer, very different in the Western world compared to us. We are not screening them. Obviously, that S in the bracket means that they're being screened in the Western world. And that's the difference in all the cancers. Although the cervical cancer is noted to be 24 per 100,000 in Mumbai, for the 2 consecutive years, 2 years ago, the numbers have been 7.5 per 100,000. And if it goes below 6, it would, as per WHO definition, become a rare disease. So we are progressing well as far as infection-related cancers are concerned. And the mortality, if you see, in my title, there is cancer mortality age standardized. Survival of those who get cancer is barely 50% in India, whereas it is 70% in US. But overall mortality, because of the absolute numbers, per 100,000 is just 64 in India, and in US it is 105. It shouldn't so happen that in pursuit of improving these goals so that we improve our survival from 50 to 70%, our incidence starts rising comparable to US. That if that happens, then we will have a little bit of misery to follow. So let's look at towards these cancer, what are the preventable ones? 40% of cancers are tobacco related, 15% to obesity, and about 15% related to infection. And infection related cancers are reducing at a breakneck speed. May it be cervical cancer, stomach cancer, penile cancer, whichever cancer, any of these are reducing at a very, very brisk speed in whole of India. Not just urban, but even in semi-urban pockets. So, and we don't know exactly what the reason. It may be good hygiene, it may be Swachh Bharat, it may be running water everywhere. It's just improving the quality of life that may have had this impact. Tobacco, as seen in the NEGM article, 1 million tobacco deaths per year during 2010. These have already crossed about 1.2 million by the time we reach 2020. So 1.2 million deaths are because of tobacco, and we need to badly do something so that we are better off. Does something help? Look at this data from UK. Continued smoking, that's the kind of rise in mortality, stopped at 50, almost half the reduction, stopped at 30, further 20% reduction, and never smokers. So obviously, those who are smokers are at a risk, and tobacco chewers are also equally at a risk, which is evident at in Mumbai also. But reducing it or stopping it does have an impact. So prolonged use of tobacco kills, and anytime stopping works, it works very, very well. These are slides that I've borrowed from Richard Pito. So since they hit with right kind of numbers. So what are the 3 main messages from tobacco point of view? is that risk is huge. Half are dead before they reach 69, and many are killed in middle ages. So stopping does work, and we need to work voraciously towards it. We have made some efforts. The tobacco victims, the way the industry was pulled in court in the United States, and there were results which made them pay huge amount of money to the victims. Similar effort is going on here, and that should reduce the effort of the industry to sell these products. Media sensitization has also helped to a great extent. And finally, a ban on sale of packeted gutka and pan masala. This has resulted in a relative reduction of about 16% in Mumbai Cancer Registry as far as oral cancer is concerned in the last 3 years. So obviously, bans and regulatory movements do work. One of the strategies that can be used is levying more and more tax. So triple the price, halve the sale, and double the revenue. That's the strategy which was used in France. So here, the top figure is the consumption that is earlier, and then we have the prices being tripled over a period of time. And that tripling of the price has reduced the consumption by half, whereas in spite of half consumption and half sales, the revenue for government was doubled. So this kind of strategy would be useful without losing any revenue. Although revenue should not be a reason for continued sale of the product, we need to look at a bigger step, zero cultivation. Some kind of alternate crop given to the farmers, incentive to the farmers, and goal would be zero cultivation by 2030. So let's look at how best we can reduce this. And if that kind of goal can be achieved, we have achieved a big thing. What would be the benefit if that reduces? Reduced cancer, reduced hypertension, reduced heart attacks and strokes, reduced burden on healthcare system, and reduced all-cause mortality. Imagine 40% of cancers and a lot of fatal heart attacks and strokes would be reduced remarkably if tobacco was to be reduced as far as it's concerned. As far as infection goes, it's already reducing. Running water, potable water, wherever there has been municipal corporation, there has been reduction in cervical cancer. You will find in one of the biggest statistics that we have is of Barshi. Barshi rural still has 20 plus incidents per 100,000 of cervical cancer, but Barshi urban has reduced to 12, just about 25 kilometers away. So it's only with personal hygiene that these things have been achieved. And if we were to utilize vaccination, I'm going to look at the effects at least 25 years down the line. So we need to do something for today. And that's feasible by various aspects of screening, which I will deal with. But obesity is another area, like tobacco, is going to have a major impact in how we deal with it. And there are various ways. There are some dietetic factors which have kept the cancer low as far as colon cancer is concerned in India, and that should be continued. But in general, what kind of food, when I look at the obesity in schools these days, we are in for a major kind of a epidemic of obesity related diseases, whether it is diabetes, hypertension, or cancer. There are about 19 cancers which are associated with obesity, and those are going to hit us 10-15 years down the line. So what we need to do, I was just giving a suggestion to the Chief Minister in state of Maharashtra, that there are multiple roads that are being formed. 2 suggestions were given. We have a coastal road, so typical distance of 16 kilometers, which today, while traveling on road, takes anywhere up to about 2 hours. If we were to do a double-decker road, and the lower level of the road could have travelators, first running at 5 kilometers, second at 10, and the third at 15. Imagine you're walking on this footpath, you walk at about 5 kilometers, you can easily step onto the first travelator. and you will walk at 10 kilometers, step on to the next. By the time you get onto the third travelator and walk on that, you're walking at 20 kilometers an hour. The longest distance, 16 kilometers, traveled in 45 minutes, producing no pollution and exercising yourself. Let's create some walking cities. And in business district, the same thing could be done to reduce vehicles, vehicular pollution less, and in general, healthy city. Obesity is one important thing that needs to be tackled right away, and that will have a major impact on how we tackle these diseases. Screening, there was a mention in the previous panel that we should have an early detection, that people should come for their checkups. One should understand that in India, the healthcare system is already stressed. We have too many people, and screening undoubtedly increases the incidence. So we need to first understand that whether screening reduces mortality, cause-specific mortality, and at least some numerical reduction in all-cause mortality. We have that for cervical cancer after the age of 30 and breast cancer after the age of 50, but not for prostate, not for lung, not for colorectal, and for any other cancer for that matter. So if we restrict our screening only when there is robust evidence of effective screening, we would look for a reduction in mortality. But all cancers being screened would have a major problem as far as incidence is concerned, and a system that is already overworked with numbers, we would be inundated with numbers that we will never be able to manage. What decides the outcome? Having gone through prevention, screening, what decides the outcome of treatment? Conforming to the evidence-based care, which we have through NCG as well as through Navya. A second opinion, which should be popularized today, Ayushman Bharat uses Navya for standardizing optimal care and for payment too. Specialization is mandatory today to improve outcomes and to prevent delays, as rightly expressed earlier by Arnie, a hub and spoke model, which could be utilized very effectively. It's being implemented in Assam. We have demonstrated similar thing in Punjab. We created a spoke and the state government created 4 other spokes, and we already have common cancers treated very effectively at that place. Our hub should be functional in the next 3 months' time. So in general, a hub and spoke model wherein an evidence-based practice is strictly followed and we reduce the mortality related to it. But how do we offer the care at the doorsteps? So dual approach. First, create a national cancer grid, which has already happened in India. There are 200 centers, all of them willing to follow the same kind of guidelines, which will offer uniformity of care and eliminating disparities in cancer care. In addition, the places where there is least amount of care, we could systematically set up cancer centers, which are hubs and spokes. So that's a distributed model, minimizing patient migration, comprehensive cancer centers as hubs, and spokes connected to these central hubs, delivering care that is de novo planned there or planned elsewhere, but less complex in nature. Typically a hub for every 40 million people, and expected cancer burden for 40 million would be about 40,000, 350 bedded facility at a 550 crore capex and 100 crore per annum. Of these, the OPEX, 50 to 70% of OPEX could be generated through paying patients or through government insurance, and the government could pay just about 30% of the residual gap. Similarly for spoke, a spoke for every 10 million. This is what we have demonstrated in Punjab, and this could be replicated at multiple places. So 10 million individuals and typically treating about 10,000 patients, 150 bedded facility at 225 crores and a recurring budget of 38 crores. This could be easily generated through paying patients. Again, both these spokes looking after free patients, below poverty line patients, partially paying patients, and all spectrum of society. This will allow a much wider and a balanced understanding of disease for people who are treating it. And that, in my opinion, would be a great impetus for solutions that can be tested in research, which are implicated, which are replicable at multiple places. At TMH, we have that model, and I would allude to about 4 or 5 practice-changing results that have come out of it. Dr. De Cruz's trial of N0 NEC changed practice globally. We have just published the results of breast cancer screening with breast clinical examination being performed by healthcare workers, having a 30% reduction in breast cancer mortality above the age of 50. So simple interventions, cost-effective interventions, easily implementable interventions is what would emerge out of the whole society being treated, and proper guided research for unique problems within India, the way we are presently tackling gallbladder cancer in various places. So typically the hub and spokes that we have created in Tata Memorial Center, we have already treated about 1.25 million patients, and the whole hospital, sorry, not 0.15 million, and National Cancer Grid has looked after about 0.75 million, which out of the total of 1.15 million patients. So there is a model that can be implemented, institutional model, state-wise model, and support through federal government, through insurance, which could come from state as well as federal government, and a directional research which could allow us never to feel the rising number of cancer patients that we are expecting as the urbanization proceeds. Thank you very much.
Thank you very much, Dr. Rajendra Badwe. In fact, today was the session on focusing on NCDs, and indeed we are privileged and honored to have the luminaries who have been working for last 30-40 years in the field of non-communicable disease. We started our day by the talk from Dr. Cherian Verghese. Then we put forward what Kerala has been doing in the NCD field. My colleagues, Dr. Satishan, Dr. Moni, Dr. Rekha, and also Gopal, Kiran, Matthew, and others, we shared our experience. And after that, there was such an exciting session that all of us were waiting for months together. And the way, in a very shortest possible time, the experience and the knowledge which was shared with us, we are all thrilled by all the stories what we have been hearing all across the globe. Kerala is also doing their bit. If we take a look at what Kerala has been doing after independence, first 5-year plan, 25 years consistently, governments have been spending at least 30% of their revenue in the health and education sector. Now, if we take a look at what we are doing now, as many of you have guided, that we have to take a look at the infrastructure. Our government has taken a bold decision, and we are improving infrastructure at all the levels, primary, secondary, and tertiary level, looking at the disease burden and what should be the priority of the state. Through KIBBI project, we are expending around 3,000 crore in the coming years. It is well supported through our state funding, through the plan funds. Now, we not only looked at the investment in the infrastructure, but also in the processes, what kind of a qualitative improvement is required, that we are doing it, and that is what my colleagues have narrated, what we have been doing in each and every program. And therefore, your incisive details and also comments and remarks will definitely help us. What are the areas where we should look into for going forward? And it was mentioned to us by all these eminent speakers that there are certain things which we have to do. And this integration and the connect of the primary healthcare with the secondary and tertiary is a non-negotiable thing that we have very well understood, sirs. We will look forward to your continued support to our effort. I was personally thinking that it is really, I would put it in this way, that we had a very little time to hear all of you, and each one of you would have given, in fact, we would have succeeded in giving more time. It would have been wonderful for us. But I know that all of you are hard pressed for the time, and in spite of that fact, all of you have come and attended. It is indeed a great privilege and honor for all of us. On my personal behalf, I thank all the speakers who have joined for today's session. I extend my sincere thanks to our Honorable Minister who have come in spite of our busy schedule and shared our vision that what we plan to do. And we earnestly look forward to each and everybody's contribution and also collaboration in coming days and months and years. Thank you very much. We will end our session here. Thank you very much.